Live now, sir.
So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, live. Very good morning to all the delegates and their faculties. After 2 days of knowledge and many new information, we are now have reached at our final concluding day. And today we are going to have excitement day because the today's learning is very hardcore. The master videos, the sessions about surgical critical care, and a very unique session of Milap which we will come across. And these videos, they are being displayed, will explained by the experienced faculties who are stalwart in their field. And these videos are videos which you are going to use in your day-to-day practice. And if you are a postgraduate or MCS trainee, you are going to answer a few of them. You going to answer about your exams. So not wasting much time, I request our respected chairpersons to take on the dais. The very first is Dr. Gyan Saurabh.
Good morning.
Good morning. Welcome, sir.
Good morning. Yeah, please.
So, sir is professor in the Lady Hardinge Medical College, New Delhi. The next chairperson is Dr. Shilpa Sharma. Ma'am is additional professor in the pediatric surgery department at the AIIMS New Delhi. And next chairperson is Dr. Siddharth Jain, who is associate professor of surgery and very critical colleague of ours as far as genitourinary trauma management is concerned. So I welcome all the respected chairpersons and I request them to run the show. The stage is all yours, ma'am.
Thank you, Dr. Dinesh. Good morning, everybody. I would like to thank the organizers of Trauma 2021 for this opportunity. It's really nice to be with the trauma team and learn and share experiences. With this, I would like to introduce the first speaker. He's Dr. Junaid Alam, a dedicated trauma surgeon and assistant professor in the Division of Trauma Surgery and Critical Care at AIIMS New Delhi. He'll be talking to us about open tracheostomy. Dr. Junaid, please. I would request the audience to please put your questions up in the chat box and we'll take them at the end of the talk.
Thank you, ma'am. Thank you so much. Thank you, ISTEC, for giving me an opportunity. Am I audible?
Yes, you're audible and your slides are visible. Please go ahead.
Thank you so much. So my topic is open tracheostomy. And this is my disclaimer. So way back 3600 BC with the pictures, tracheostomy being depicted on the Egyptian artisanry. And the term tracheostomy from the Greek root estom, that means mouth, and it refers to the making of a semi-permanent or permanent opening in the airway. Before 20th century, there was no established principles for the tracheostomy operation. This gentleman, Chevalier Jackson, he established the principles of tracheostomy operation in the beginning of 20th century, and these have grossly remained unchanged till present date. There are many types of the surgical airways. The importance are the cricothyroidotomy, and it is usually done in emergency. The tracheostomy, it can be done either by open method or percutaneous method. Tracheostomy is very important procedure to save the life of the patient. And in today's time, there is a trend, or you can say that there is a paradigm shift from the open tracheostomy to the percutaneous tracheostomy. But the percutaneous tracheostomy cannot be done in all the hospital, as it requires more expertise and it requires 24/7 ultrasonography or bronchoscopy, and also learning curve for the PCT is more as compared to the open tracheostomy. And if PCT fails, then you will land up into open tracheostomy. And in the meanwhile, the open tracheostomy can be done a resource-constrained facility with little experience. So every surgeon must know how to do the open tracheostomy. The open tracheostomy can be done either in emergency or elective. But in case of elective, you have to take the consent of the patient. It can be done under local anesthesia or general anesthesia. It is temporary or permanent. The various indication of the open tracheostomy is upper airway obstruction. It may be due to oncological cause or neurological cause, infective cause or inflammatory cause, inability to intubate the patient, the pancreatial maxillofacial trauma, the laryngeal and significant neck trauma, the expected prolonged intubation in case of the prolonged mechanical ventilation. A tracheostomy replaces the endotracheal intubation to wean off anesthetized patient to decrease the rate of subglottis stenosis, and it decreases the dead space and working of breathing and providing the better control on the secretion of the lower respiratory tract. And other causes are facilitating the pulmonary toilet and adjunct to head and neck surgery and obstructive sleep apnea. As far as the contraindication is concerned, there is no absolute contraindication of the tracheostomy, but there is a strong relative contraindication in elective tracheostomy, not in emergency. And they are the uncorrected coagulopathy, inability to tolerate the procedure in respect of the medical perspective or anatomical consideration like stenosis and obstruction or tracheal fistula. And if there is a recent instrumentation of the cervical spine and active local inflammation or infection in the area, that is the relative contraindication in elective tracheostomy. Before going to the steps of the tracheostomy, let us see the various instruments which is used in the tracheostomy. And if you see here, you will see the mosquito and artery forceps, the hook retractor, the leg and back, and tracheal dilator, the right angle forceps, needle with syringe, the LEs, cautery, the suction, scissors, bipolar cautery tape, and the forceps, marker, and the blades and suture to secure. The formula to select the tracheostomy tube in the children is based on either based on the age or based on the weight. A standard age-based formula is internal diameter is equal to age in years divided by 4 plus 4 millimeter, and a standard weight-based formula is internal diameter is equal to weight in kg divided by 4 plus 3.5 millimeter. And there is also a traditional method of diagnosing the internal diameter by the tip of your the little finger of the patient. As well as in case of the adult, the size usually varies between 7.5 to 8.5 in case of male, and in case of the female, it varies between 6.5 to 7.5. Regarding the positioning of the patient, if you will taking the patient in the elective mode, it is better to take the patient in the operation theater with adequate lighting and stocked with large selection of the tracheostomy tube, and consent must be taken before taking the patient. The position of the patient should be laid supine, and it is luxury, but because in trauma we can't get these type of the patient usually, but if we get this is luxury. And the neck should be fully extended by placing the shoulder roll under the upper back area, and the head is stabilized on the head ring. In case of the cervical spine injury, the patient extension, neck extension should not be done. And in case of the children, hyperextension may cause the damage to the thoracic inlet vessel. So local antiseptic solution is applied, and a sterile condition should be maintained throughout the procedure, and intravenous antibiotic are given according to the hospital protocol. Because before going to the details, before going to the incision, or you must know the anterior neck anatomy, because it is surrounded by a large vessels and the thyroid gland. In the landmark, basically it marked by the marking pencil or marking pen, and this is the cranial end, and this is the caudal end, and this is the thyroid cartilage notch, and this is the cricoid cartilage prominence, and this is the external notch. So the incision must be either two finger above the external notch or midway between the cricoid cartilage and external notch. So I have made the video step by step. First, local infiltration. So the local the incision site should be infiltrated with 5 to 10 ml of 0.2% of lignocaine solution mixed with adrenaline in the concentration of 1:2 lakhs. And after infiltrating the local anesthesia, we have to give the incision. The incision through the skin is made either halfway between the inferior border of the cricoid cartilage or external notch, or 2 finger above the external notch. The size is usually 3 centimeter to 4 centimeter, but it may extend as exposure is less or as necessary if the adverse anatomical conditions are encountered. Once the skin inside, the dissection continues through the subcutaneous fat and thin platysma fiber and superficial investing layer of the deep cervical fascia are entered and a strap muscle identified. Once the strap muscle identified, blunt dissection in the midline through linea alba is carried out, and the strap muscle is retracted laterally using the Liegenbeck retractor. If the thyroid isthmus come in between, it must be retracted upward. The tracheal wall is identified and cleaned. As you're seeing, thyroid isthmus is retracting upward. The tracheal ring is identified and it is cleaned. After that, the dissection carried out till the trachea visualized, and exposure should be done properly. See here, the trachea is being visualized, the white glistening structure. Once the trachea visualized, we have to check the tracheal position by using the syringe filled with saline. See this? On expiration, bubble is coming. So we are at the right place. And after that, you have to make incision. The incision should be at the second or third tracheal cartilage, and it should be U-shaped incision. And once the incision is made, using the tracheal dilator to dilate this area, you are seeing the ET tube, and the anesthetist should be instructed to withdraw the tube under the direction of the surgeon. When the tip is immediately above the tracheostomy, the withdrawal should be stopped, and the tracheostomy tube is inserted from one side and gently rotated placed. The cuff of the tracheostomy tube is inflated and it is connected to the anesthetic machine. And you have to check the CO2 as well as the any subcutaneous emphysema around the neck is there or not. And after that, you secure the tracheostomy tube by using the sutures, as we are seeing in this video. We are securing the ET tube using the sutures. After securing, you can do the dressing, and the Velcro tape may be applied, but it should not be too tight or too loose. See, after tracheostomy, the tracheostomy tube is connected to the ventilator and the position of the patient. So what are the various complications? The various complications are the immediate complication, in which the hemorrhage can occur, pneumothorax can develop, air embolism, pneumomediastinum, false passage may be there, esophageal injury can occur. In early tracheoesophageal fistula may develop, dislodgement may occur, infection may occur, dysphagia, pneumothorax, subcutaneous emphysema, and in late tracheal stenosis, difficulty in decolonization, and tracheal cutaneous fistula or scar may develop. And this is some difficult intubation. This is our patient. This is the same patient in which we have done the open tracheostomy. This is large goiter, short neck, and post-burn contraction. These are the patient in which there is a difficulty in doing the tracheostomy. Thank you so much. Thank you so much.
Thank you, Dr. Junaid. That was an excellent demonstration of tracheostomy. Just one comment: if the patient is already on an endotracheal tube, you can calculate the size of the tracheostomy by reducing 0.5. In the pictures that you showed with difficult intubation, the goiter size was quite large. So how would you suggest to go ahead for in that case with tracheostomy? Would an ultrasound help in location?
In case of the large thyroid goiter, you may cut the isthmus of the thyroid. You have to give the incision either vertically or transverse as per the USG finding of the patient. And if you have seen in my video that we are retracting the thyroid isthmus. In case of the large thyroid, it will come in your field. You can cut and divide the thyroid isthmus, and then you expose your area.
Have you ever encountered difficulty in localizing the trachea in the center? Because in trauma cases, it may be displaced on either side depending on the trauma.
Usually in the patient of the cervical spine injury, which we get encountered usually, in that case, because we don't make the patient in extension position, so we have to keep in mind that the trachea is deviated or not deviated, because all depends on the patient position. If you'll see the patient position, if it is not right, then you can't do. So always make the patient straight and then do the tracheostomy and check the tracheostomy pattern. Check the trachea, it is in proper position or not. with your hand, or you can use the saline filled with the syringe.
Thank you. Any questions from the other panelists, Dr. Siddharth, Dr. Gyan?
That's okay. Junaid, I have just one question. Are there any words of wisdom regarding bedside or emergency department tracheostomies that sometime you have to do in red areas? How difficult or how different they are from elective tracheostomies?
Can you repeat the question?
Say a patient present in acute trauma and you have to do a ED tracheostomy in emergency department. What is your experience regarding that? How difficult they can be, and what precautions you usually take at that time?
Usually the patient came in the ED and there is a difficult intubation, and if there is any delay, we usually used to go for the cricothyroidectomy. And if we ship the patient in the OT and then we do, usually, if there is any difficulty.
What would you suggest for post-operative care of tracheostomy so that it doesn't come out, and the care that is needed to maintain humidity?
So it can be done with the trained nurses or trained resident. And while handling this, we always take care of the position of the trachea. You must stabilize that one before doing any dressing or handling the trachea. Or if you want to change the bedsheet or you want to change the dressing around that area, you must check the, you must stabilize first and then do the dressing.
And after removal of this tracheostomy, sometimes we've seen granuloma formation at the site, and these patients may bleed. So what would you recommend for that? Have you encountered any torrential hemorrhage because of that?
Ma'am, usually we, in case of the temporary, we don't keep this more, but sometimes it may get encountered. So in that case, usually we take the patient into OT and we do the cautery of that area, and we, if necessary, then we incise that area, and after that a strapping can be done.
Thank you so much, Dr. Junaid. I request Dr. Saurabh to please invite the next speaker.
Thank you, Dr. Shilpa, and thank you, Dr. Junaid, for the wonderful presentation. Okay, so yeah, now I would like to invite Dr. Pratyusha, who is an associate professor in the Division of Trauma Surgery and Critical Care, All India Institute of Medical Sciences, New Delhi. And her talk is on percutaneous tracheostomy. So Dr. Pratyusha, please.
Good morning, respected chairpersons and audiences. Can you hear me? Are my slides visible?
Yes.
Yes, yes, your slides are visible and you're very much audible, Dr. Pratyusha.
Yeah. Already Dr. Junaid has talked about the indications of open tracheostomy and everything about open tracheostomy. So basically, I will be talking about percutaneous tracheostomy. It's a compared to open tracheostomy, it's a recent procedure. It was invented by Siadlia in 1985. After its introduction, it has largely replaced open tracheostomy in the setting of ICU setting. One of the main advantages of this percutaneous tracheostomy is that it can be done bedside. It doesn't require shifting the patient to operating room, or it can be also done under local anesthesia and sedation. It doesn't require even administration of general anesthesia. Because of these advantages, more and more patients in ICU are undergoing percutaneous tracheostomy rather than open tracheostomy. Still, a surgeon performing percutaneous tracheostomy must be well versed with open tracheostomy, because in case of difficulty, he might need it to convert. So, percutaneous tracheostomy, it involves blunt dissection of pretracheal fascia and followed by dilatation of trachea over the guide wire, similar to Seldinger technique. Indications of PCT are mainly in patients who are anticipated to have prolonged ventilatory stay, and those patients who are not able to protect their airways, like neurosurgery patients who are M5 or M3 who are being discharged. In those patients, this procedure is indicated. Now, the main contraindications are unstable cervical spine injuries, because we cannot fully extend the neck, and uncontrollable coagulopathy, and also in infants. Relative contraindications are enlarged thyroid gland and difficult anatomy like short neck, morbid obesity, limited neck extension, or local malignancy, or uncorrected coagulopathy. All of these can be overcome by experience and or with an adjunct like bronchoscopy or ultrasound. Now, word about timing of PCT. When should be done tracheostomy in the setting of ICU? So the timing of tracheostomy is still debatable. Some people have not found any benefit of early versus late. However, at our center, we prefer early tracheostomy because we have seen that there are some advantage of doing early tracheostomy, because the number of ventilator days are reduced. There are various types of percutaneous tracheostomy, like Ciaglia, serial dilatation technique, Ciaglia, single dilator technique, Greg's percutaneous technique, Pantone translaryngeal tracheostomy, Flora's percutaneous tracheostomy, and balloon dilational tracheostomy. But I will be showing you the Ciaglia single dilator technique, because it is the most commonly performed technique, and this is the technique which we are performing at our center, and it is more convenient. Before we proceed for the procedure, relevant neck anatomy should be well versed with the anatomy, as already talked by Dr. Junaid. So this is the thyroid cartilage, and this is the cricoid cartilage. And this is the first tracheal ring, second and third tracheal ring. So in this technique, we are going to puncture the trachea between the cricoid and first tracheal ring, or between second and first tracheal ring. So this is our percutaneous tracheostomy site. The equipments which we need for this technique is our local anesthetic medication for sedation, and short paralytic agent, a laryngoscope plate, lignocaine jelly, and a tracheostomy tube with collar. This tracheostomy tube should be pre-checked for any leak, and we need a percutaneous tracheostomy set. So this is the Cook's percutaneous tracheostomy set, which is available with us. It costs around 14 to 15,000, and it has 15 number surgical blade and one introducer needle, and the guide wire for cannulating the tracheal dilator, 14 French small tracheal dilator, and then it has a single stage large progressive dilator, also known as Rhino. And then these are tracheostomy inducer. These are not for the dilatation of trachea. These are only for the loading the tracheostomy tube. They are being given in various sizes, like 7.5, 8.5, or 9, for corresponding to the tracheostomy size. And this is the dissector which we need. Now, few practical aspects before proceeding to the procedure. The proper patient selection is imperative for PCT. Anatomic landmark should be easily palpable in patients selected for this procedure, and a space of at least 3 to 4 centimeters between cricoid and sternal node should be available. Informed consent should be taken, and if there is any patient or anticoagulation, it should be withheld a night before. Patient should be NPO, and there should be continuous monitoring with blood pressure, ECG, and pulse oximetry and capnography. Before we proceed, if patient should be neck should be extended fully, And this is done by placing a roll beneath the shoulder blade. So as already seen in this picture, this patient is neck is fully extended and we can see the relevant anatomic landmarks clearly. Also, before we begin with the procedure, patient is already intubated and the patient and FiO2 is increased to 100% 3 to 5 minutes before the procedure, and we give adequate sedation in form of 50 to 100 ml of fentanyl or 5 milligrams of midazolam and a short-acting palliative agent like rocuramine. And after we have given our medication, and then a person at the head end will introduce the laryngoscope and deflate the ET cuff, endotracheal cuff, and withdraw the endotracheal cuff until the cuff is visualized just below the vocal cord, and then re-inflate the cuff. And then patient is cleaned and draped, and we proceed with our procedure. So divided it in 5 to 6 steps, and so first we mark the landmarks, mark the thyroid and the sternal notch, and the cricoid cartilage, and this is the point where we are injecting our local anesthetic. So this local anesthetic is 2% lignocaine with adrenaline, around 10 ml of phenylbutyl. Now with the 15 number blade, we give around 1 to 2 centimeter transverse incision, and we do a blunt dissection of the pretracheal fascia. This blunt dissection will displace the anterior jugular vein, and it will minimize the bleeding. So after we have made a blunt dissection, then with the non-dominant hand, we fix the trachea, and with the right hand, right-handed, we introduce the needle on the syringe, and we check for the proper placement of this needle in the trachea by aspirating saline syringe. We should be very careful in introducing the needle so that we don't injure the posterior tracheal canal. Now, after confirming the position, we are introducing the guide wire into the trachea through the needle. So this guide wire is inserted, and we withdraw our needle. Now with this guide wire, we are going to first introduce a 14 small tracheal dilator, and we'll use a twisting movement to dilate the tract in the trachea. And the movement should be very careful and controlled. So after we have dilated the trachea, we are now introducing a single progressive dilator, also known as rhino. It is loaded on a protective sheath. It has got black markings with various markings. It corresponds to the amount of diameter. So usually we have to insert it till the black mark. So we have inserted it till black mark, which corresponds to 38 inch. And now we have removed the rhino. We can see the tracheal opening that their bubble was coming. Now, this is the loading dilator is on which the tracheostomy tube has been preloaded, and now we are going to introduce this tracheostomy to the use of. And we take out this loading additive and sheet and inflate the balloon. We confirm the positioning of correct positioning of tube by checking the EtCO2. Here we can see that EtCO2 is rising, so it is in the trachea. Once the tracheostomy is placed in position, we tell the person at the head end to withdraw the endotracheal tubes, and we connect it with the ventilator. And as already told by Dr. Junaid, we do 4-point fixation of this tracheostomy tube so that it avoids any accidental decavation. And we also then fix it with the tape, which has been given with the tracheostomy tube. Now, a few words about the procedural adjuncts. So here, what I have shown you was done without aid of bronchoscopy or ultrasound. Nowadays, more and more people are doing this with the aid of bronchoscopy and ultrasonography. There are advantages of bronchoscopy. The main advantage is that real-time confirmation of the needle placement, and there is avoidance of posterior tracheal wall injury. However, the concerns are that it is associated with increase in the intracranial pressure, and also there is a fall in the oxygen saturation while doing the bronchoscopy. So it can't be done in patients with neurological condition and patients who require high ventilatory settings with high FiO2 requirement and high PO requirement. Also, you need an experienced intensivist or anesthetist with expertise in bronchoscopy. If you don't have an experienced bronchoscopist or you have a bronchoscope, then you can still perform this PCT, as we have been routinely doing it in our neurosurgery ward and in our surgical ICU also. And there are guidelines also who do not recommend its routine use, and it is essential only if operator is inexperienced and the anatomy of the neck is difficult. Similar to bronchoscopy, ultrasonography can be used in guiding the needle placement in the trachea, and it can also help us in identifying aberrant vessels or enlarged thigh. It is inexpensive and readily available, and it can be used, but routine use is still not recommended because it is still not available everywhere. Now, complications of PCT are similar to open tracheostomy. In immediate, there may be loss of airway, hypoxia, pneumothorax, posterior tracheal wall injury, esophageal injury, bleeding. And in early, there could be tracheal tube obstruction, surgical emphysema, posterior tracheal wall injury. In delayed, it could be subglottic stenosis, swallowing difficulty, and voice change, and tracheoesophageal fistula, and very rare tracheoinnominate bleeding. Few word about post-tracheostomy care and decannulation. You have to keep the stomach clean and dry, and the cough pressure should be maintained at 20 to 25. And adequate humidification is advised using moist saline gauze, or there are humidifier available. Suction should be done gently and directly. And when the patient is fit for decannulation, as and when the patient should be decannulated. Now, so to summarize my presentation, it's an established procedure in critically ill patients, and with proper patient selection and wide use of ultrasound and bronchoscopy, more and more patients can be offered PCT. It has got some learning curve, but it can be done. And there are various techniques available, but one should stick to the technique which with maximum individual comfort, and we have to keep it consistently, keep doing it, which will increase the success rate. Any questions?
Thank you, Dr. Pratisha. That was an excellent presentation. A very quick question. Oh, what would you recommend for doing a percutaneous tracheostomy in a COVID positive patient? Would you recommend taking any extra precaution or something different from the routine one?
So extra precaution, we have to don a PPE. This is the extra precaution, and we need 2 people. And also we need to pre-oxygenate the patient in between. And the time of hypoxia should be minimized in these patients.
Okay, would you recommend giving a complete neuromuscular paralysis for COVID positive patient while doing a PTC, percutaneous tracheostomy?
No, I would not recommend.
Okay, usually the evidence suggests that one extra precaution that we need to take in for doing a percutaneous tracheostomy in a COVID positive patient is to give a complete neuromuscular paralysis to avoid extreme cough reflux. So that's one of the things being said, but yes, I would agree that practices are still different. Evidence hasn't emerged completely as far a particular procedure is concerned. And just a quick comment about your experience with percutaneous tracheostomy in somebody having a very high BMI. Would you recommend doing that in those patients? For example, super obese or morbidly obese, just your practical experience.
Sir, actually they have short neck and the anatomy is not visible in those patients. So I would be very slightly skeptical of doing percutaneous. But if we have a bronchoscopy and then we can try. But for the beginners, I would not recommend.
Thank you so much, Dr. Pratyusha. And if is there any other question from the panelist or from anyone to Dr. Pratyusha after such an excellent presentation?
I think very well presented. Yes, slightly beyond the time.
Yes. Okay. But it was worth it. So yeah. So with this, we will move forward, and may I request Dr. Kapil to introduce the next speaker? Thank you, Dr. Pratyusha. Yeah.
I'll take the place of Dr.
Okay.
Kapil, busy with some schedules.
Okay. Yeah, please, Dr. Siddharth. Yeah, please.
I am Dr. Siddharth. For next master video, I'd like to invite Dr. Narinder Chaudhary, our young and talented colleague. He is Associate Professor in Division of Trauma Surgery and Critical Care at AIIMS, New Delhi. And he would tell us about laparoscopic gastrostomies. Dr. Narinder, please. Sir, please kindly take care of time. It's about 15 minutes for you.
Yes, sir. Thank you, sir. Noted, sir. And without wasting much time, I am just sharing my video. So I hope that I am visible and audible as well.
Yes, sir, clearly.
Okay, so without wasting much time, I am directly jumping towards the video, and I will discuss the indications, contraindications, and various precautions taken while doing this laparoscopic gastrostomy, meanwhile, while running the video. So this laparoscopic gastrostomy, we started as a part of intramural project in the patients who requires long-term assisted enteral feed. This is the first step of doing any laparoscopic procedure, that is creating the pneumoperitoneum in the umbilical incision. And right now we are creating the pneumoperitoneum. The pressure of the pneumoperitoneum we usually keep is between 12 to 13 mmHg. And here we are placing the port after creating the pneumoperitoneum. The port placement, we usually place 3 ports, 2 ports of 12 mm size and 1 port of 5 mm size. The 12 mm port is the umbilical port, which is used for the camera and visualization. The another 12 mm port we usually placed 5 to 10 centimeter proximal in the mid clavicular line, slightly lateral to the mid clavicular line as a working port. And the third port, 5 mm port, we usually place in the midline, just sub-xiphoid space. And after creating pneumoperitoneum, placing the port, the next critical space is inspecting the pylorus for ruling out any pyloric stenosis, because it may be the catastrophic to do the gastrostomy in a gastric outlet obstruction. So just by visualizing the pyloric end, we just rule out any gastric outlet obstruction. After that, the next critical step is placing the purse string suture over the anterior gastric wall. So the optimum site of placing the percutaneous, this purse string suture is the anterior gastric wall at the body of the stomach, just near to the greater curvature. So we are just placing the purse string suture so that we can secure the gastrostomy tube once it is placed inside the stomach. So we are just doing the intracorporeal suturing, and we are just placing the purse string suture using Vicryl 3O round body suture. So we are just making it. Meanwhile, we are making the purse string suture. I just want to make you aware that we started this procedure after having certain complications while placing the percutaneous endoscopic gastrostomy tube. We found that multiple patients develop infection at the gastrostomy site. So we found that that may be because of the gastrostomy tube we placed through endoscopic vision, that they has to pass through the oral cavity, and there are the chances that that oral cavity passage will leads to the infection. So for the long-term assisted enteral feed in a patient, particularly in the head injury patient who are not able to accept feed orally, or in severe maxillofacial injury patients who require long-term feed but they are not able to accept orally, we started placement of gastrostomy tube under laparoscopic guidance, and for them for long-term enteral feed. So after placing the purse string suture, now the time arrived to secure this purse string suture by the 4 transfacial sutures. So by strapping the anterior stomach wall with the anterior abdominal wall will be more secure and will be avoiding the displacement of the gastrostomy tube. So we are just putting 4 transfacial sutures at the 4 places around the purse string suture that will be strapped after placement of the gastrostomy tube. So right now we are placing the first transfacial suture, and while putting this transfacial suture, we used epidural needle while looping the Prolene suture through it as an indigenous technique for placement of transfacial suture rather than using any particular instrument for this transfacial suture. So like this, we are just looping the transfacial suture, and now just we are pulling it out. So like this, we are looping it out, and we have just placed first transfacial suture that is just proximal to this this purse string suture. And after that, we will again place the next gastrostomy transfacial suture. So the need of placing this transfacial like this, we are again from outside, we are putting now the second transfacial suture. We place a small nick around maybe 1 mm, and then we just place the needle, epidural needle. We are just pushing inside with the Prolene loop inside it. We are just pushing it. And now we are just loosening the Prolene thread inside so that it can make the loop, which was visible initially. Now again, we are making the second transfacial suture. We are taking the bite over the anterior stomach wall. We are just holding the needle, and by just taking the second transfacial suture, we will again loop it through the Prolene loop, which was placed through the epidural needle, and we will pull it out. Just stay with me. It will be clear how we will pull it out. And we are just pulling it out. Just we are putting the needle inside. Yes, we are going inside, and this is the epidural needle which I just shown you in the previous video. This is the needle with Prolene loop inside. Now losing the Prolene loop so that I can get through this loop inside, and now just picking the suture and just pulling it out. So it will go transfacially, and I will cut the thread near the needle so that I can remove the needle through my 12 mm working port. So now the one loop of the thread goes outside transfacially, and I'm just cutting it out, and I just delivered out the needle, and one more transfacial suture has been placed over the anterior stomach wall. Now it's the time for the third transfacial suture. Yes, now again we are placing the needle from outside in, and just inside we just pulled it out, and now it's the place for third transfacial suture. So while we are placing the third transfacial suture, I just want to discuss the need of these transfacial sutures. So for initial, once we started doing laparoscopic gastrostomy for these patients, 1 or 2 patients, we found that this gastrostomy tube got displaced, maybe because of accidental puncture while of the Foley's bulb while placing inside, or maybe because of the loosened that persisting suture. So we thought, why not secure it extra with these 4 transfacial sutures, so that we can, even if there is a chances of slightly loosening of the persisting, this transfacial suture will take care of dislodgement of the tube, and they remain strap this anterior stomach wall with the anterior abdominal wall. So again, we are just looping it out. And after that, we started placing these transfacial sutures in every patient who underwent laparoscopic gastrostomy. And the results were very encouraging. And till now, we have completed almost 10 patients with the laparoscopic gastrostomy. And we have not found any of the patients who had the displaced gastrostomy tube after securing these 4 transfacial sutures. So I can say that these are one of the most important step while performing laparoscopic gastrostomy. Again, we just pulled it, the third transfacial suture out through the loop, and we will cut the needle and delivered it outside. After that, we will place the 4th and the final transfacial suture. So as it is evident on the image, we can say that these transfacial sutures will be placed all around the persisting suture in a way that they will strap the anterior stomach wall from all around. So this is the final transfacial suture. Again, we are looping it inside, and we are just passing our needle holder through this loop and just holding the needle and just cutting it out and making the transfacial suture evident. So meanwhile, placing this transfacial suture, the last transfacial suture is near the greater curvature, where we can observe that large vessels are there. So inadvertent injury chances are high, and you should be very cautious while placing this 4th transfacial suture, so that you may not injure inadvertently any vessel that may leads to bleed, and that may just obscure your operative field. This is the last step of the transfacial suture, and we are just looping it out through the indigenous technique of using epidural needle. Now the needle has been passed through the loop, and the loop tightened out. It's just, we are just pulling it out through the transfacial suture, and now I will cut the needle and remove it out through the working port. So like this, I just catch hold the suture near the needle and just place the seizure, and I just cut it out and deliver it out. So here ends the placement of 4 transfacial suture as well as placement of persisting suture over the anterior abdominal wall. Now the time arrived for the creation of stoma over the anterior stomach wall. So till now, every procedure is reversible. If anything happens, we can reverse the procedure. But once creation of the gastrostomy is there or creation of stoma or the anterior stomach wall is there, then the procedure is irreversible. Now you have to place something, or if something happens wrong, then you have to convert it to the open also. So while doing the stoma, you must be very careful that you must not inadvertently cut the transfacial suture or the purse string suture, which is very close by. So it is advisable that you should make a large purse string suture around the future gastrostomy site, so that you have a working space where you can actually place the harmonic scalpel and you can actually make the anterior gastrostoma. So just we are creating a hole inside the anterior stomach wall using harmonic scalpel. And while creating this anterior stomach hole, you must be very careful that you must not damage inadvertently the posterior stomach wall. So it is very essential that you should lift it up. So whenever I am using this harmonic scalpel, I am just lifting the anterior stomach wall up, so that there will be the gap between the anterior stomach wall and posterior stomach wall. So my another instrument is just lifting up the stomach wall, and your every step should be under vision. It should not be a blind step. You should not poke anything blindly inside the stomach. So it should be under vision and it should be guarded. So with this, I am able to enter the stomach cavity inside. My Maryland is inside the stomach. Now I am just making a hole on the anterior abdominal wall for the placement of 18 French silicone Foley's catheter. We are using Foley's catheter owing to low cost, as well as silicone Foley's catheter can be stayed for a long time till the maturation of this particular stoma. So right now we are just delivering the 18 French silicone Foley's catheter inside. And while holding this catheter, be careful that you should hold from the tip, the blue tip. You should not hold this catheter from the inflating bulb side, because if you hold the catheter from the inflating bulb side, then you may actually can damage the inflating bulb. So the bulb will not inflate, and there are higher chances that it may dislodge in the future side. We have experienced in one patient, and we got the lesson from that patient that we should not hold anything at the site of inflating bulb. So while inflating the bulb, I just make sure that the Foley's catheter is within the stomach cavity only. After ascertaining that yes, it is within the stomach cavity, the next step is the tightening the purse string. So I just deflated fully and I tighten the gastrostomy tube tight over the purse string suture. I am just tightening it out, making at least 4 suture knots. And you should also make sure that these knots should be tightened enough so that they may not loose. After that, I am just pulling it out and strapping the anterior stomach wall against the anterior abdominal wall. And now the time arrived for securing the transfacial sutures. So this is the first transfacial suture which we are securing. And like that, this is the laparoscopic view while securing the 4th transfacial suture. So like this, we secured all the sutures here. This is the last step, and with suturing these transfacial sutures, I just secure the gastrostomy tube around the site, and this is the final step. This is the completion of gastrostomy with beautifully strapped anterior stomach wall with the anterior abdominal wall. With this, my video ends here. And in the post-operative care, we usually keep the patient NPO for next 24 hours. And after that, with the advent of bowel sounds and in the absence of any guarding and rigidity, we usually start test feed at completion of 24 hours. And once the patient tolerates test feed, we start the complete feed through the gastrostomy tube. Thank you.
So thank you, Dr. Narinder. That was very well presented, and several practical improvisations in laparoscopic techniques. One can see that. So we have some questions from audience. First one is, what is advantage of your lap technique over open gastrostomy when it can be done under local anesthesia? And please go ahead with your answer for that.
Open gastrostomy, for that we at least that's a slightly moribund procedure, and a large incision is required, and all the advantage of laparoscopy can be added with the laparoscopic gastrostomy that may not be with the open gastrostomy. And the second thing is this laparoscopic view is very beautiful, and you can see every step under direct vision. You can place every step under vision, which may not be possible in a local gastrostomy where the access is very limited.
And what about the morbid obese patients and some anatomical difficulties? Would you prefer it open, or lap has an advantage over that?
Even obesity is a relative indication for the laparoscopic laparoscopic gastrostomy. So in obese patients, yes, laparoscopic view is very good, and it is recommended to have the laparoscopic gastrostomy in obese patients. Side by side, the indications of laparoscopic gastrostomy should be there. We usually place the laparoscopic gastrostomy in the patients who are not able to take it orally, especially in the severe head injury patient or severe maxillofacial injuries, where they are not able to accept it orally and we have to give the enteral feed beyond 4 weeks. Yes, we have to place the gastrostomy too.
And one question for the advantage of postgraduates. When do you change these tubes? What is your take on use of Mallicot catheters in place of silicone? And how do you close this gastrostomy once the requirement is over for enteral feeding?
So for any placement of, once we place the gastrostomy tube, we use silicone catheter because the infection rate is lower than the Mallicot's catheter. And nowadays, this is easily available and not so much costly also. And once we place it for at least 4 to 6 weeks till the complete adhesions of anterior stomach wall and anterior abdominal wall is there. After that, we can remove it at the end of the 4 to 6 weeks if the need arise, or we can remove after 6 weeks electively once, because by continuous using this for the feeding and other purposes, there are chances that it gets blocked, or it sometimes there is chances of infection. So after 6 weeks, yes, it is routinely exchanged. And before that, if any need arise, then we can change. Otherwise, we will not change.
Thank you very much. Any other questions to be added?
Just a quick one, Dr. Narendra. Would you do routine endoscopy in these patients? Prior to doing a lap gastrostomy, especially if you have ended up in a patient of gastroesophageal reflux disease, and that's going to be a mess. So would you recommend a routine endoscopy prior to doing a lap gastrostomy in all the patient, or would you not?
Sir, we routinely in our center, we are not doing routine endoscopy before placing the laparoscopic gastrostomy tube, because our patient population is a trauma patient population, and presence of gastroesophageal reflux and all these, we have not encountered, although our series is very small, and I'm not denying that we may not encounter, but still we have not encountered. And the chances of gastroesophageal reflux in these patients are rare, according to me. So that's why we have not place them as a routine endoscopy prior to laparoscopic gastrostomy. But yes, if you have indicated, I will go through the literature and we will change if it is really required.
Dr. Narendra, you are perfectly fine in not getting an endoscopy, even in trauma as well as non-trauma patient. Evidence doesn't support it. It is not found to be cost effective. Thank you so much for your presentation. And now I'd like to introduce our new speaker, Dr. Abhinav Kumar, Associate Professor in the Division of Trauma Surgery and Critical Care. And he will talk on percutaneous endoscopic gastrostomy. Over to Dr. Abhinav Kumar.
Yeah, thank you, sir. Am I audible?
Yes, Dr. Abhinav, you're audible, but we are yet to see your presentation.
Yeah. Is it on now?
Yes, it is. Your presentation is visible. Kindly put it on full screen mode.
Yeah.
That's fine.
Yeah.
Perfect. Please begin.
Thank you, sir, for your kind introduction. And at the outset, my sincere thanks to the organizing committee and the ISTEC for giving us the opportunity to talk on this topic. This is the greeting from my institute, where I'm working as an associate professor in Division of Trauma Surgery and Critical Care. And today I will be talking about the percutaneous endoscopic gastrostomy. What we have a tag is there's a full technique. I have nothing to disclose. And as a usual, as a all postgraduate or as surgical clinicians, when all know that the enteral alimentation is safe and cost-effective, and it's also immunogenic too. Endoscopic procedure is minimally invasive procedure for enteral feeding. As the days of minimal invasive techniques are emerging, there will be always a question to how to go about a percutaneous or the surgical gastrostomy. This question will keep on coming, but the answer is it's a technique which one has to master it, and it's simple. If you master the technique, it becomes simple for you. And when we are talking about percutaneous technique, what are the factors which are important? Because you must know this. What is the first is timing, when you should be doing it. Second, who should be doing it? It's a gastroenterologist or a surgeon. Procedure and how we are doing it will demonstrate in a few minutes. So timing, when to do it, we will be sticking about all the indications in the trauma setting, acute trauma setting, especially those patients with severe head injury which require alimentation, supplementation of the enteral feeding. That is the severe head injury patient, DIA, maxillofacial, we have heard about in the next previous presentations. The others are where the neurological diseases, neoplastic conditions, and sometimes a rare one when you decompression for the unresectable distal obstructions. Who should be doing this? This is a question which keeps on coming. But the essence is in surgical field, in the medical field, the answer is, bottom line is, do no further harm. You master the technique and it becomes simple for you. And this is how we learned. We first of all learned from the gastroenterology and then we mastered the technique. And the literature says that the complications are operator dependent. So you have to have patience and master the skill. It's simple. And how we do it, it's said that preparation is the key, and you must take for all patients, whatever presentations you have, you must indications is the take an informed consent. And especially in these type of patients, the patient won't be giving a consent, then you must take from the legally authorized representative. The patient should be fasting for 12 hours. Antibiotics as per your institute protocol. You can give IV just the sedations for these patients. And for the percutaneous technique, there are two techniques which are there. One is through peroral and the abdominal. Peroral, it is the pull technique. It was introduced by Goddard in 1980s in the children. It started, and this has become a history now, and it's because common days now a procedure. Abdominal techniques, it was introduced by Russell. Those for those patients where you are not able to do the oral technique, maybe because of malignancy and all. So coming to the procedures, this is what we have: a PEG tube, and you prepare with that has a tube and all the equipment, guide wire, introducer needle with xylocaine, syringe, and the Caesar. They are all with the PEG set available. Open it up and arrange on the table. And on other causes, what I said, for any procedure, what you have to do, you prepare for the open also. And patient is positioned supine. The two techniques are there. The two persons are there. One at the head end who does the endoscopy, and the second one who does the percutaneous technique. And this is what you are doing with. When you enter the endoscope and do as a diagnostic endoscopy, what we call it, and it is done in from the craniocaudal. When you start and just getting you back here, this is the pylorus. When you enter the stomach, you will see the rugosity present there. And the meaning of diagnostic is you look for any pathology present inside the stomach. First orientation is ureocaudal is the pylorus. This is the pylorus there, and then you retroflex your come back and retroflex and see this is the gastric fundus and the gastroesophageal junctions and craniocaudal directions. You must look for it. Then the second part is critical step during your diagnostic lab endoscopy is you must have to choose the site of your gastrostomy. So you went to side, meaning that you have to go from the lesser curvature to the anterior curvature and look for rule out any abnormal pathology. The second step, critical step, is inflate the stomach. Inflate the stomach so that it becomes like a balloon. So it becomes easier to place an introducer needle. And this is what you are taking, inflate. Then we see there is an absence of rugosity present here. And then we go for a safe track technique. What is the safe track technique? is the technique where you have to place a percutaneous needle. So what you have to do, there are two ways of doing it. One, you try to focus the light of the endoscope so that there is not, you have to pinpoint it so that the light is not diffused. And second, at the same time, the surgeon outside place a finger. That's a finger indentation, and it goes side by side. It do with the German condition. Then take the introducer needle and place where the maximum light of focus is, and it should be visible here. So when you are inside the technique, pass the guide wire. Here I will tell you there are two ways of doing this. One is that when you pass the guide wire, and this is the snare which you call it, a snare, and just pass on the guide wire. With the help of the snare, catch hold of the guide wire and pull this out. One is when you have to place a guide wire against the stomach wall and place the needle. This is simpler, easy, which we have demonstrated here. And this is the guide wire which comes down. Sorry. With the help of the catch hold of the guide wire with the snare and just simply pull out the endoscope. And this is the beginning of your pull technique, what you are trying to do. The guide wire comes out along with the endoscope. You have one for one end, you pass on the guide wire, it goes. And with the help of, when you come out with the endoscope, the guide wire comes out of oral cavity. This is how it goes. And at the causes, what you said, this should be as gentle and communicated as and should be, so that it should not damage the any gastroesophageal junction. This is the big gastrostomy tube. This is the bumper. This is a tapered needle, and place the this one, the gastrostomy tube within the guide wire, so that make a loop and hinge it around the guide wire. This is the technique, and you loop this bumper inside the loop of the guide wire at the other end is, and just encircle this. And what you have to be careful about, you have to just not leave it here. See what we are trying, that this loop, what you are trying to do, this loop should be minimum, because when it comes down at the G junction, it may injure the G junction sometimes. So it has to be as smooth as the guide wire it looks like to be. And the second step is lubricate the tube. This is a must. This is a must. You must lubricate the tube with the Gelocane jelly, which is provided in the PEX set. Apply it well through it, and gently, when you are done with it, gently again communicate with both of them. Gently pull the guide wire from the abdominal wall. And as it goes, it should be as gentle as enough. It goes as you pass the rise tube, it goes. So when you are there, sorry, it should be gentle. And when we are there, then we'll find a resistance here. That means that the tip of the wire has come across the stomach wall. And here you place a small incision. This is what we are giving with the needle. And the technique is place the two fingers along this. This will act as a counter traction and the traction along the guide wire. And you gently, with the to and fro motions or simply rotating it, just see the tip of the silicone tube coming in out. Here what I said, and there are two techniques people say that place a 1 centimeter incision. I generally make the incision graduated, because the moment the resistance goes up, the tube comes out in a very fast. So generally it should be graded. This is what I advocate for it. And again, place a counter traction, and gently the tube and the other end of the tube will come out. See, this is how it is. And you have to grade your skin incisions. When you have done with it, it simply comes out as a pop. So again, you communicate with the surgeon who is standing with the endoscope, and the endoscope is placed on the bumper, and with the communication, it goes inside your stomach. This is how it looks when the PEG tube comes inside from the inside, and gently this traction should be so gentle, and it's gently place the bumper against the stomach wall. And you should not be in a hurry, because the advantage of endoscopy or laparoscopy is whatever you are doing, it is visible. And you have to gently place it along the stomach wall, that is along the anterior stomach wall between the lesser and greater curvature, just at the junction of the body and antrum. Generally, and the second thing, and you have to localize with it, that's where you are sending the tube which is being fixed, and you are not pulling it too hard against the stomach wall. Place the sheath, there's the stopper there, which goes along and placed, and it is placed along the abdominal skin. This is the way how you fix the tube. This is provided in the PEG set, and there are the two clips. Simply just place it and don't try to give much of the traction here. Not of the traction. And when you are seeing, I'm trying to look at it whether it is not too tight or not loose. That's the key here. That's the key here. And when you are done with it, we have checked with endoscopy. Then place the two hinges along this. Just keep the tube in place. Here you don't have to place a suture and the needle and make a loop. There are two and placed along the 90-degree along, one at the other side and one at the other side. The second one is, then you, after this, there is a marking here. And ideally what it should be there, it should be between 2 to 4. 2 to 4, but what is it, not get into the fix that I'll fix it at 4 or 2. But what you have to visualize it so that it is not snugly fit. It depends on the abdominal wall thickness. And place the stopper, and there is a marking at the X here which shows where you have to cut the tube and connect the tubing that has a two ends. Then one is for the feeding and the other is for doing a flushing of the tube. When the feeding is stopped, you flush the tube. So this is just placed along it. And the second is, after you've done it, you must reconfirm the bumper again. This is critical all the time when you're saying that the bumper has to be not too tight and not too loose. So do the check endoscopy, and it starts again looking at the pylorus, come to the G junctions, whether this is what the G junctions looks like along the, as you draw your endoscope out, look along the wall of the esophagus all through till you have reached the upper end, to rule out any advent injury which you may have encountered during your placement of a guide wire or an endoscope or while putting the PEG tube. And this is what we call as the check endoscopy, and this what it concludes your endoscopic procedures. And again, what I said earlier, this has two ends, the feeding and for the flush end, and connect to the drainage, and that's what we keep it the drainage for at least 12 to 24 hours. And the next day, when you look for the clinical examinations, if there is everything is okay, no signs of any pruritus, then you can start the feeding on the next day. So conclude, it's a minimally invasive technique. It is safe and reliable. If you learn the technique, how you do it, and you adhere to the steps, the critical steps of the procedures, and the complication rate are less. Thank you for your patient hearing, and I'm happy to take any questions.
Thank you, Dr. Abhinav. It was actually a very informative session. I found it extremely informative, and I'm sure all the audience and panelists would also have. One question is, did you ever encounter distal migration of internal bumper causing gastric outlet obstruction?
Yeah. Okay, this is again, I have during the talk, I have reiterated the placement care of the tube is a must. Care of the tube starts during your endoscopic procedure when you are placing the tube bumper along the abdominal wall. Second, when you are fixing the tube to the abdominal wall externally. These are the two things which you look for. And if the tube has come with the markings, which I have highlighted here, 2, 4, 6. So whenever you are there in your post-operative period, surgically we have taken the care of it. In the post-operative period, you must look for that. And the second part is you don't give a too liberal incision. If you have a liberal incision, the chances of getting migrations are more. If the hinges, the fixation is inadequate, it may migrate. That is the one. People have said for additional safety, you can place a loop, what you do for an open surgical procedure, that you make a loop after 5 or 10 centimeter and place this, what you call, the sutures, and for the additional fixations. But distal migrations, we have not encountered until the fixations becomes direct. And sometimes patients may take out, then you may encounter, but we have not yet encountered. But if you take care of this, this is taken care of.
Okay, as we lack time, a very quick question from the audience. How to remove this tube when purpose is solved, by Dr. Dinesh Gora?
Yeah. There are two techniques when you see endoscopy is what you call, it's an augmentation of your OPD procedures. One is when the tube tract gets mature. This is after 6 weeks. Generally, after the 6 weeks, the tract is formed. You can just gently take out the percutaneously. Otherwise, the best preferred technique is put an endoscope. It hardly takes a 5 minutes and take out the tube.
Okay, so I think with this, I'll hand over the stage to the moderator, Dr. Dinesh.
Thank you very much, sir.
Thank you
very much for running so successful this session. And I extend my greetings on behalf of organizing committee of ISTEC to all our esteemed faculty and speaker and chairpersons to run this great show of teaching. And I cannot deny that this will help our listener, our practitioner to step these procedures in their practice and to learn more. Thank you very much. And I conclude this session here. Have a nice day.
Thank you.
And with this, we proceed with the next session, which is again a very important session of surgical critical care. As far as not only the trauma patients management is concerned, but any surgical unit, there has to be a good basic knowledge about the critical care. Although you have your critical care specialist with along you, but a good basic knowledge of critical care is must to run any good surgical program successfully. So run this session, I request our chairpersons to take the dais, and we have Professor Girish Bakshi. He is professor and head of the unit in Grants Government Medical College and Sir JJ Group of Hospital, Mumbai. And another chairperson is Dr. Richa Agrawal, additional professor and backbone of the critical care services at the JPNHS AIIMS, New Delhi. I welcome to both the chairpersons and request Professor Girish to kindly run the show. Thank you. Dr. Girish, stage is all yours. You are muted, sir.
Yes. Good morning. At the outset, I would like to thank ISTAC and AIIMS JP Apex Trauma Center for organizing such an academic extravaganza where we all are learning. We are learning something or the other. And I would also like to thank them for giving me an opportunity to chair this session. To begin with the session, we start with our first speaker, Dr. Vijayan Purushottam, who is working as assistant professor in Department of Trauma Surgery, CMC Vellore. And he is going to talk about basics of ventilation for surgeons. The stage is all yours, Dr. Vijayan. Please start.
Thank you all for such a wonderful introduction and for giving me this opportunity. I will go straight for the presentation. Yeah. The topic is basics of mechanical ventilation, but I would proceed with starting with the respiratory physiology, because to understand basics of mechanical ventilation, we need a better understanding of the respiratory physiology and the basics of respiratory pathology. So if you ask what is respiration to most of our medical colleagues, or if you read in the books, you are going to get an answer like this. But I am here to try to simplify this as much as possible for a basic understanding. If you ask me what is respiration, I would say it is nothing but an exchange of gases. There is only two processes that is involved. One is, I'm sorry. There is only two processes that is involved. One is inspiration of oxygen and expiration of carbon dioxide. This is as simple as that. Try to keep it simple, then you'll understand as we go along. So in this, when you look at it, oxygenation is actually the transfer of oxygen from the atmosphere to the lungs, does not require any active process, actually a passive process. It diffuses by gradient. But as against the ventilation, ventilation needs active respiration that to happen to exhale the carbon dioxide. And to simplify the concept even more, I would say that oxygen deals with alveoli and arteries in the lung parenchyma, and ventilation deals with the chest wall and muscles of respiration. And if you ask me, the most important of these two is actually ventilation, because oxygen does not need an active transport. So with this, I would like to introduce a new concept called the ventilation and the perfusion matching. If you look at this particular slide, you can see that this particular alveoli is damaged because of, let's say, for example, consolidation. So there is filled with inflammatory fluid, but the blood flow is still happening to this particular alveoli. What is happening? There's no oxygen transport here. That means it's a poorly ventilated alveoli. This is called the pathological shunt. As compared to this particular image, where you can see the oxygenation is happening, but the blood flow is not there. For example, a pathology like pulmonary embolism, there is no blood flow. This is called you are ventilating a dead space, which is of no use. If you use the same concept in a ventilation lung zone, in a standing patient, zone 1 is literally equal to a dead space, because air travels through least resistance. It will go to the upper lobe, as against a blood flow which goes towards the lower lobe, which is equivalent to zone 3. So basically, there is a physiological dead space. There is a physiological shunt that's happening in the lung in a normal patient. Ideally, usually most of our oxygen transport happens in the middle zone. With these two concepts, I would like to introduce the pathology called respiratory failure. As I already said, the problem with respiration is only two things. One is oxygenation and one is carbon dioxide. If there is failure to oxygenate, it is called respiratory failure. If it's failure to expel carbon dioxide, it is also called respiratory failure. For classification purpose, we classify as anything to do with oxygen is a type 1 respiratory failure. Anything to do with abnormal carbon dioxide elevation is type 2 respiratory failure. If you look at this oxygen saturation curve, we surgeons, or not only surgeons, all the doctors starts worrying when the saturation is 90. Why is this magic number of 90? If you look at this curve, you know, at a saturation probe of 90, the oxygenation, partial pressure of oxygenation is 60. The atmospheric air that you breathe has 20% of oxygen. So if you calculate this PaO2 by the FiO2 of 20 in atmospheric air, you will reach a target of 300. We all know this 300 is the limit for considering a patient has normal lungs or ARDS lungs. So anywhere the patient reaches a saturation of 90, that means the patient's partial oxygenation is 60. That is equal to, we are at the state of 300 PF ratio, which is the borderline to decide whether the patient is in ARDS or not. So coming on to the respiratory failure in trauma, because of what is our field of expertise, it's been proven that these are the factors that actually has a high precedence for respiratory failure in trauma. Elevated ISS, elderly age, massive transfusion, chest wall trauma, hypertension, and long bone injuries with causing fat embolisms. If you look at this picture, let's say, and we'll take a case in isolation, there's only a lung contusion because of trauma, blunt injury chest of the trauma. You see that the alveoli are filled with lots of inflammatory fluid. As I already said in the first slide, anything to deal with oxygenation is either artery or alveoli. We can see the alveoli is also damaged and the artery is also damaged. So the problem is, in this case, will be dealing with oxygenation. That is type 1 respiratory failure. Let's say there is a patient who has got only an isolated rib fracture with flail chest with no lung or parenchymal or arterial injury. We can say that there is a chest wall abnormality. As I already said, anything to do with chest wall hampers with carbon dioxide exhalation. So we are calling it type 2 respiratory failure. But we all know in trauma, these two things doesn't happen in isolation. It always happens in combination. So in trauma, we will have a type 1 as well as type 2 respiratory failure, also can be called as mixed respiratory failure. So this is explaining the same thing what I said. Anything to do with alveoli or artery, it's a type 1 respiratory failure. Anything to do with muscles of respiration or chest wall, it's a type 2 respiratory failure. Or type 1 mixed failure, which is the most common thing that we usually see in a setting of trauma. I would like to introduce you a case scenario. It's a 22-year-old male who has undergone emergency laparotomy. Post-operative day 2, complaints of severe abdominal pain. No analgesics has been given. So patient has got a saturation of 92, PCO2 of 35, PaO2 of 65. Although within the normal range, there is mild oxygenation deficit. So what will you do for this patient? Obviously, we will give analgesics, but however, we will oxygenate these patients in the ward. If you look at oxygenating devices, we use lots of devices like nasal prongs, Hudson mask, Venturi devices, but there is a difference in this oxygenating device. One is called the variable oxygenating device. What does it mean is the FiO2 delivered to the patient's lung actually varies. And there's something called fixed oxygenating device. That means the FiO2 delivered to the patient has a fixed FiO2. So you can control the FiO2 that delivers to the patient. You can look at the variable performance device, that is nasal prongs, Hudson mask, or fixed performance device can be Venturi, reservoir bag, non-invasive ventilation, and mechanical ventilation. If you look at variable flow nasal cannula, that means you are giving multiple, you can actually give 2 liters, 3 liters, 4 liters, or 6 liters. So the FiO2 that you're delivering through the nasal prong varies. But however, the patient is also breathing atmospheric air. So there's a mix-up of this 100% oxygen along with atmospheric air. So there's a mix-up of gases happens in the nasopharynx. So the final FiO2 that's delivered to the lung parenchyma varies, and it depends on the respiratory rate. As compared, this high flow nasal cannula works on the same principle. Similarly, the same principle works for Hudson mask also. A reservoir bag has a rebreathing mask. So though we say there's 100% FiO2, practically speaking, evidence has shown that only 60 to 90% of the FiO2 is delivered in a reservoir bag. But for all theoretical purpose, a reservoir bag has got a definitive FiO2 of 100%. This Venturi device is one of the wonderful devices ever made. If you look at it, it's internationally color coded, and every color has a particular FiO2 and the amount of liters of oxygen that has to be delivered through this particular code. This works on a principle called Bernoulli's principle. If you look at this particular video, the man is blowing air into this space between, but the balloon is getting pulled to each other. What happens is when a flow of air goes through a medium, it causes a vacuum in that place, and that pulls the surrounding structures. To look at this particular Venturi device, you give the oxygen through this particular entry point. As the air goes, as a vacuum is created in this chamber. If you look at these particular holes are made in such that the size and configuration, the atmospheric air is pulled in through these holes, and the mix-up of FiO2 happens. So it gives an approximately a perfect figure of FiO2 of 60. And you can actually have from 24 to 60% Venturi devices. So this is with variable and fixed oxygenating device. With that, I will proceed with the case 2 scenario, a patient who has undergone bowel resection with anastomosis, but developed anastomotic leak. If you look at, there's a problem with this saturation is 84, PaO2 is low, PCO2 is very low. That means patient has got type 1 respiratory failure and trying to hyperventilate, washing out carbon dioxide. In this patient, what will we do? Apart from source control, we will put him in ICU and we will intubate him and put him on a mechanical ventilation. The first thing, the problem in this patient is oxygenation. If you look at this particular chart, you can see that as the FiO2 increases, the partial pressure of oxygen in the lungs also increases. So once you put a patient on ventilator, if the PaO2 is low, you increase the FiO2, automatically the PaO2 is increased. Our target in a patient in any shock, especially in trauma, which is a mixed shock, the shock is about delivery of oxygen to the distal tissues, the distal perfusion. So FiO2 has to be increased to achieve the PaO2 upfront. And The second thing that is involved in oxygenation is called alveoli. The amount of surface area that is required for the oxygen to go should be more. If you give a positive end expiratory pressure to keep the alveoli open at the end of expiration, that means at the end of expiration, the lungs are all collapsing, but there is still the alveoli are kept open. That has to be there for oxygenation to get diffused. If you have a PEEP of 0, if you see that with a PEEP of 0, the surface area is very less. But if the PEEP is 10, the surface area is very more. So in such a case, the area is more. The oxygenation transport between the alveoli and the arteries also will be much better. We always keep a basic PEEP of 5. Why is that magic number of PEEP of 5 in a ventilator? Because the vocal cords in a normal patient use that PEEP of 5 for the alveolus. When you bypass that vocal cords through an endotracheal tube or a tracheostomy, that PEEP is gone. So the minimum PEEP for a patient should be 5, except for exceptional reasons like bronchoalveolar fistula, where you will keep a PEEP of 0, but the basic PEEP of 5 is necessary. But having said that, with respect to oxygenation, increase in PEEP causes increase in peripheral transfer of oxygen to the arteries and the peripheral perfusion on partial pressure of oxygen in the arteries. The third case scenario I would like to bring is that a patient who is overdosed with respiratory depression. So the problem with this patient is PaCO2 is very high. So the target is we should reduce the PaCO2. To do that, we know that the problem is with ventilation. So you should ventilate the patient more. If you look at this particular graph, the PaCO2 falls down as you increase the minute ventilation. Minute ventilation is nothing but tidal volume into respiratory rate. So to decrease the PaCO2, either you increase the tidal volume, to decrease the PaCO2 or increase the respiratory rate. Tidal volume is like a balloon. You want more air to come out of the balloon at the end of your leaving the mouth. You have to put in more air into the balloon. It's as simple as that. So to get more carbon dioxide out of the lung volume, to wash all the gases that is inside the alveoli, you have to give in more gas. That is minute tidal volume. So the more tidal volume you give, the more CO2 gets washed out. But having said this, giving a tidal volume should be within the limits of safety of mechanical ventilation. That is 6 to 10 ml, 6 to 8 ml per kg per ventilation. Again, as I said, CO2 depends directly on the respiratory rate. As you decrease, if you want to decrease the PaCO2, you increase the respiratory rate, which is washing out the patient. So ventilation depends on respiratory rate and tidal volume. Oxygenation in ventilator depends on FiO2 and positive end expiratory pressure. But with the respiratory, I want to introduce to a new concept in ventilation. It's called the inspiratory expiratory ratio. It's called the IE ratio. If you look at in this particular slide, this is the inspiration. The flow of oxygenation is the inspiration, which takes only 1 second. But expiration takes the complete 2 seconds for the entire carbon dioxide to get washed. Usually the ventilator settings in a normal patient is approximately 1:2. That is, for every second of oxygenation, you have 2 seconds of ventilation. But in a patient with high CO2, especially for in this case scenario, what will we do? We try to increase the respiratory rate. That's what I told right now. But what happens when you increase the respiratory rate? Like let's say from 20, I'm increased the respiratory rate to 30. In 60 seconds, the ventilator is forced to give 30 breaths. That means ventilator will give 1 second of oxygenation and 1 second of ventilation. But what happens when you reduce the ventilatory time? That when you increase the respiratory rate is increased always at the expenses of expiration. So when you do that, you don't completely exhale your carbon dioxide. Some amount of carbon dioxide gets trapped into the alveolar space, which is not our target. Our target is to expire as much carbon dioxide outside. So when you trap this carbon dioxide, this is called auto peeping, which will not serve your purpose. So what will you do in this scenario? As I said, ventilation is always at the expense of expiration. So you be smart, do some changes in the ventilator so that the IE ratio of 1:2 is maintained. So basically you reduce the time of inspiration. You reduce, instead of 1 second of oxygenation, you reduce it to 0.7 and you give more time, almost 1.3 seconds for the carbon dioxide to get exhaled. So at least the graph touches the baseline. So this has to be seen when you see in a graph in a ventilator, so that there is no auto peeping that develops. So in short, respiration is nothing but oxygenation and carbon dioxide delivery exhalation. Anything abnormal with oxygenation is type 1 respiratory failure. Anything abnormal with ventilation is type 2 respiratory failure. In oxygenation, you can have fixed devices or variable device, but when the patient goes on to mechanical ventilation, if you want to increase the PaO2, increase the FiO2 and increase the PEEP. If you want to decrease the CO2, you increase the tidal volume and increase the respiratory rate within the limits of IE ratio and safe mechanical ventilation. Thank you.
An excellent talk, Dr. You have really put the perspective of basics of ventilation very clear, because as surgeons, we don't talk about ventilation. We always leave it up to the anesthetist. But those of us who are working in ICU, who are managing the ventilators, we know a little bit, but you have made the concept very clear. I can't see any questions in the chat box right now. Dr. Richa, who is the chairperson, do you have any questions? Would you like to ask any question, or do you have anything in mind you can ask?
Not exactly, Dr. Vijayan. It was an excellent talk, very informative, very precise talk for the surgeons. Very good to hear from you. And if there are no questions from the participants, I think we move on the next lecture.
Thank you.
Right. The next, our next speaker is Dr. Soumya Ghoshal. He is an assistant professor at AIIMS Nagpur. It's my pleasure to introduce Dr. Soumya. He has been our student, a very sincere student and a very competent surgeon. So over to Dr. Soumya Ghoshal for the next lecture, which is interpretation of arterial blood gases.
Dr. Soumya, you are muted. Please kindly unmute yourself.
Dr. Soumya, you're muted, right? Dr. Soumya, you can start.
Now am I audible?
Yes, you are audible and slides are clearly visible. You can start.
First of all, a very good morning to all of you. I will be just discussing the very basic of interpretation of ABG. Interpretation of ABG requires basically a very basic understanding of the physiology, a few simple equations and a step-by-step approach. But the most important thing is to put everything at the clinical context of the patient at hand. What are the values we get from an ABG? These are pH, PaCO2, PaO2. This has been extensively discussed in the previous class. These three measures are directly measured in an ABG machine. Next two, that is bicarbonate and oxygen saturation, are derived from calculation. So PaCO2 gives us the idea about the ventilatory status of the patient. The oxygenation status is determined by the PaO2, oxygen saturation, and also PaCO2. pH, PaCO2, and bicarbonate gives us the acid-base status of the patient. By now, we are very familiar with the concept of ventilation and oxygenation, thanks to the wonderful class taken by Dr. Vijayan. So I would say that half of the class on ABG is already over. We already learned how PaO2 and PaCO2 help us to determine the respiratory status of the patient. But before judging the respiratory status, we need to see to the clinical picture of the patient. That patient who underwent emergency laparotomy, on post-operative day 2, he had a PaO2 of 65 millimeter of Hg. Who knows, it may be a venous blood sample. So always look at the monitor. Always look at the saturation of the patient. If the saturation is corresponding to the PaO2, then your blood sample is probably an arterial one. Suppose this patient is on ventilator and we are giving him 100% of oxygen. FiO2 is 100. So there should be a reason to be worried about. So always ask what is the FiO2 of the patient before determining the oxygen status of the patient. The general dictum is that PaO2 is normally should be 4 to 5 times of FiO2. If PaO2 and FiO2 ratio is less than 300, then we should search for any problem in oxygenation. Now we'll learn something about acid-base problem. Acidemia or alkalemia are the physiological state those are solely dependent upon the blood pH. Acidemia is pH less than 7.35. Alkalemia is pH more than 7.45. For the sake of calculation and interpretation, we'll consider the normal value 7.4. pH of the blood depends upon partial pressure of carbon dioxide in arterial blood and bicarbonate both. The ratio is important. So after determining the acidemia and alkalemia, we'll go on to acidosis and alkalosis. These terminologies are completely different. Acidosis and alkalosis are the processes which tend to drive the pH to an abnormal range. In an ABG, they both run together hand in hand. Just one of them is a primary disorder and other is a compensatory. So a patient with a normal pH might have no acidemia or alkalemia, but he may have acidosis or alkalosis both. When partial pressure of carbon dioxide is deranged, then it is a disorder of respiratory system. When the bicarbonate is deranged, there is a metabolic disorder. PCO2 increases in respiratory acidosis, PCO2 will decrease in respiratory alkalosis. Bicarbonate will decrease in metabolic acidosis and it will increase in metabolic alkalosis. So we need to determine which one of these is the primary disorder. So this is our step 2. For the sake of calculation, again, we will consider PaCO2 as 40 as a normal value and bicarbonates 24 as a normal value. So the primary disorder, which is our step 2, is one which is trying to drag the pH along with it. So that disorder which is in direction of the pH. Suppose in this patient who underwent emergency bowel resection and anastomosis on postoperative day 5, is on ABG, his pH is 7.34. So he is acidemic, but his PaCO2 is 36, that is in alkalotic range, and his bicarbonate is 19. So if you see this bicarbonate, derangement is bicarbonate is in direct relationship with the pH. So he is having a primary metabolic acidosis. In this 50-year-old male, he has sustained a thoracic trauma, fell from stairs, respiratory rate 40 per minute. His pH is 7.5. So patient is having alkalemia. His PCO2 is 29.3. This is in alkalotic range. His bicarbonate is 23.1, that is acidotic. So his primary disorder will be primary respiratory alkalosis. Now body has a very efficient mechanism, that is a buffer system that resists any change in pH. The respiratory compensation that occurs in metabolic disorder, that is a very quick one, but it is not that efficient. If you see, the compensatory change in PaCO2 is in the same direction of the change in bicarbonate. Similarly, in metabolic compensation of respiratory disorder, the change in bicarbonate, the direction of change is at the same direction to the change in carbon dioxide partial pressure. But metabolic compensation is slow to occur at acute phase. Once the kidney takes over in chronic phase, it becomes very effective. So we need to determine any respiratory disorder, whether it is an acute one or a chronic one. Either way, compensation is just an attempt to normalize the pH, but it never actually successful. It is not possible to fully compensate to a normal range. And remember, it does not, and it never overcompensate. If a patient is not compensating as predicted, a second or sometimes a third acid-base abnormality may be present. And that brings us to the step number 3. The predicted PaCO2 is calculated in response to a metabolic acidosis by a formula that is known as Unter's formula. Now, the predicted PaCO2 is the 1.5 times of the bicarbonate plus 8. In our case, bicarbonate is 19. So PaCO2 predicted will be 1.5 into 19 plus 8, that is 36.5. But I personally think this calculation is very hard to remember at the bedside. So there is an easier method. What is this? If bicarbonate decreases by 1, CO2 should at least decrease by 1 in metabolic acidosis. Here, our bicarbonate is 19. So bicarbonate, it is decreased by 5 from normal value of 24. So CO2 should at least be 40 minus 5, that is 35. So we can say that patient is having a metabolic acidosis with an appropriate compensation. Suppose this patient has a PaCO2 of 26 instead of 36. So we would say that it is a metabolic acidosis with an additional respiratory alkalosis. There is also a shortcut to know whether the compensation is appropriate or not. It is also scientifically proven. CO2 is equal to the first 2 digits after the decimal point of pH in appropriate compensation in a metabolic acid-base disorder. Suppose in our case, CO2 is 36. First 2 digit after decimal point is 34. So these are almost equal. So we can say quickly that the compensation is appropriate. Similarly, metabolic alkalosis also, there is a formula to know the change in PaCO2. That is, change in PaCO2 is equal to the 0.7 into the change in bicarbonate. But this response in metabolic alkalosis is not as vigorous as the response to metabolic acidosis. All we have to know in our surgical ward, the common causes of metabolic alkalosis, that is loss of fluid, loss of potassium, and loss of chloride. And in this situation, we should consider resuscitation with IV fluid. How do you know that a respiratory acidosis is acute or chronic in nature? Look at the patient history. Secondly, we should know that bicarbonate rises by 1 for every 10 rise in carbon dioxide in acute respiratory acidosis. So for example, if carbon dioxide is 60, is 60, then there is rise of carbon dioxide by 20. So bicarbonate should be at least 2 more than the normal value, that is 24 plus 2, that is 26. In chronic case, once kidney takes over, this rise of bicarbonate becomes very efficient. It becomes 4 instead of 1 for every 10 rise in CO2. This is a very simple diagram which can help to memorize the compensatory mechanism in respiratory disorder. In acute respiratory acidosis, the rise of bicarbonate is 1 for each 10 rise in CO2. In chronic respiratory acidosis, this becomes 4. In acute respiratory alkalosis, the fall of bicarbonate is 2 for every 10 fall in PCO2, and in chronic cases, it becomes 5. So pH should be more towards normal in chronic respiratory disorder. So coming to an example, a 40-year-old male alcoholic, he was found at roadside unconscious. His ABG showed a pH of 7.26. So he is acidemic. His PaCO2 is 60. So he is also having respiratory acidosis, and his bicarbonate is also 16. That is, patient is also having metabolic acidosis. So if you can see that here the direction of change of PCO2 and bicarbonate is opposite to each other. So how do we proceed in that case? You can go either way. You can consider metabolic acidosis as a primary one or a respiratory acidosis as a primary one. Let's solve it step by step. First, acidemia or alkalemia. His pH was acidemic, so he is in acidemia. Second step, what is the primary disorder? We will consider a respiratory acidosis in case, and we will assume that it is an acute one. Now we will calculate the compensation. What is the compensation? Bicarbonate rise by 1 for every 10 rise in CO2. So CO2 rise here is 20. So bicarbonate will rise by 2. So the predicted bicarbonate will be 24 plus 2, that is around 26. But his actual bicarbonate here is 16. So we must consider a presence of a second disorder, that is a metabolic acidosis. So the clues to the mixed acid-base disorders are that PaCO2 and bicarbonate moves in opposite direction, a normal pH and abnormal PaCO2 or bicarbonate, or pH changes in an opposite direction for a known primary disorder. Suppose pH, bicarbonate and PaCO2 all are normal. Even that, it does not mean that the acid-base status is normal. Look for the electrolytes. This brings us to the step 4, mind the anion gap. What is anion gap? Body is obsessed with electroneutrality. The total concentration of cation is equal to the total concentration of anion. The cation pool consists of largely with sodium and some unmeasured cation. And in the anion pool, it consists of bicarbonate and chloride and some unmeasured anion. Now, the anion gap is the difference between the unmeasured anion and unmeasured cation. We generally ignore the value of potassium because potassium varies very little in patient to patient. So if you see the basic calculation of anion gap is the difference between the sodium and the combined bicarbonate and chloride. Normal value of anion gap in body is 12 to 16. In case of non-anion gap metabolic acidosis, where there is a loss of bicarbonate and there is also a compensatory increase of chloride, but anion gap remains same. In case of elevated anion gap metabolic acidosis, there is some addition of a pathological acid. Acid dissociates into H+ and other anions. H+ is buffered by the bicarbonate, so bicarbonate will decrease, but chloride remains same, and that those anions will be added to the unmeasured anion pool. So our anion gap will be increased. So anion gap measurement is a very important tool to assess some hidden metabolic disorder in our body. So I will summarize my talk here. My take-home message will be check FiO2 and saturation before commenting on oxygenation of the patient. PaCO2, that has been already discussed in the previous lecture. It gives us a very valuable idea regarding the ventilation of the patient. By checking PaCO2, we have to assess whether the patient is ventilating adequately or not. Normal pH does not mean no acidosis or alkalosis, and always check for appropriate compensation. If not appropriate, a second disorder may be present. And lastly, is it an anion gap acidosis? So look at the electrolytes. So I will end my lecture by saying that treat the patient, not the ABG, see to the overall clinical picture. Thank you.
Thank you, Dr. Soumya, for a very crisp talk. You tried to make ABG very simpler by this talk. I don't see any questions here, but I just want to reiterate what Dr. Soumya said, that always interpret the ABG in context to the clinical condition of the patient. And yes, you can use the ABG to see whether your treatment is going in the right direction or not. Okay, over to Dr. Girish for the next talk.
Thank you, Dr. Soumya. Thank you. And a lucid and a clear concept what you have given. Now, may I introduce the next speaker, who is Dr. Madhur Unyal, who is Assistant Professor in the Department of Trauma Surgery and Critical Care, AIIMS Rishikesh. And he's going to talk about interpretation of viscoelastic assays in trauma. Dr. Madhur.
Good afternoon, everybody. I'm Dr. Madhur Unyal. Is my slide visible, please?
No, your slide is still not visible. You are visible, but your slide is not visible.
I'm sharing the screen. Administrator, can you please help me?
Can the technical team please help him?
Click on share button.
I need your help.
Hello, sir. Click on share button and choose your PowerPoint tab.
Escape. Just click on this.
Dr. Madhur, they are telling us if you can see the share screen, you can just share the screen, tap that button. Yes. Yes, now we are seeing it. Can you make it full screen, please?
Yes, sir.
Yeah.
Good morning, all. My topic is interpretation of viscoelastic assays in trauma ICU. So the first two questions that come into our mind are, what are viscoelastics and why are they important? So viscoelastic assays are the assays which measure the tensile strength of the clot. So why are they important? Viscoelastics are not something new. They have been around since 1948. But what has made them more popular to the conventional time-tested PTINR or APTT as we call them? The coagulation property of only plasma component can be assessed by these conventional tests, which are PTNR or APTT as we call them. They tell us nothing about factor 17, factor 13. They give us no information about fibrinolysis. They give us no information about overall strength of a clot. And they tell us only about the amount of thrombin which is generated for the onset of clotting mechanism. They don't even tell us about the integration between fibrinogen and clotting factors. So yes, now we'll be talking in very simple terms about how do we interpret these things. I've tried to make them as simple, and please pardon my if I made them too generalized. So when we talk about the thrombus, broadly categorized into 4 parts. The first part is where there is an intimal injury. Whenever there is an intimal injury in the vessel, the platelets get activated and they plug the intima, forming a loose plug. This plug is further reinforced by clotting factors. Which clotting factors we don't need to know, neither for the interpretation or for any other things when we talk about interpretation of viscoelastics in ICU. Then this plug, which has been reinforced by clotting factors, gets an add-on glue upon it, which is the fibrin component. So this makes a plug more stable one by adding some mushy mush to it. And last but not the least, to this glue, other clot supporting cells like RBCs and other cells which are present in the blood, they glow and make a clot which is stable enough to sustain or to stop the bleeding. So now we know all the 4 parts. We know that in each part, the first part platelets are taking place, second part clotting factors, fibrin, and then other support cells. So now what happens in TEG or ROTEM? We have 2 viscoelastic assays. One is thromboelastogram and another is rotational thromboelastometry. In principle, they're more or less the same. They cannot differ too much. The only difference is, which I will tell you in this slide. Here we can see that there is a cup, which is a very small cup, in which around 0.36 ml of whole blood is taken. Well, this is a very important question which comes into the minds of residents. Do we take a clotted blood or do we take citrated blood? Because at some places it is mentioned that you take citrated blood, while in some places it is mentioned that you take the whole blood as such. Since we are talking here about ICU, we presume that this TEG machine is present inside the ICU, and you will not be spending any time from transferring the blood to the TEG machine. If it is so, then you don't need to put the blood in a citrated vial. But all the hospitals are not such fortunate to have TEG machine in the ICU. They might have a centralized TEG machine, and the blood needs to be transported from ICU to there, and the interpretation is done there. In these cases, we take the blood in the citrated vial, and we take the blood to the TEG machine, where a small amount of calcium carbonate, which is usually present in the cup, is added, which absorbs the citrate part of the blood, and blood becomes the whole blood again and does the normal coagulation process. So in this small cup of blood, a pin is suspended. If we do a transaction of this pin, or if we see the cross section of this pin, it is not exactly circular. It has 2 minute flanges on both of its sides. What does these flanges do? It provides resistance as the blood starts clotting. So this pin rotates in a to and fro motion in thromboelastogram. While in ROTEM, the pin remains stationary and the cup rotates. In older times, like I talked about, that Dr. Hertz in Germany started in 1948, this pin was connected to a pointer, which was then which made its impression upon a carbon cylinder. But now this has been taken over by computers, and the motion of the pin is sensed by a sensor in the computer, and the tracings are made. We see, whenever we see the black structure you see here in the tracing, has movements both above the axis and below the axis as well. This is because of the to and fro motion. If the pin just rotated towards one action, we would have motion in one axis only, but it moves in to and fro motion. So we see a motion above the axis and below the axis. Like I said, in ROTEM, the pin oscillates, cup remains stationary, while in TEG, the cup oscillates and pin remains stationary. As the coagulation occurs, the pin adheres to the clot, and then it starts to begin to move to it. The magnitude of the pin motion is directly proportional to the clot strength. The stronger the clot is, the stronger the pin will adhere to the clot, and more it will move. There will be more friction and less slippage of pin. And the pin motion, like I said, is graphically displayed by a computer. So let's see these graphs and do a very simple interpretation. Here we see that the process has started, but the pin is suspended into the clot. The cup is oscillating. We will do, since we have to talk about both the viscoelastics like TEG and ROTEM, here we will talk about TEG, and at the end, I'll give its extrapolation to ROTEM so that we understand both the processes and don't get confused with one and the other. So these tracings which I'm about to show are tracings of thromboelastogram. So first, as the coagulation starts, the cup oscillates while the pin does not adhere to the clot and nothing happens. When the clotting begins, the pin starts adhering to the clot and more the strength of the clot increases, the more and more tracings go up and down the axis. Then at one point of time, when the clot reaches its maximum strength, the pin tracings have the maximum amplitude, and then with the start of fibrinolysis, the motion of the pin decreases, the pin again starts slipping, and the amplitude starts decreasing. Here we can see that the fibrinolysis has started beginning because the amplitude has been going down. So that means the clot is started to disintegrate and the pin is starting to slip. So now this is the simplest of graph and it has a simpleness of explanation. So how do we analyze this graph? So for this, we have taken 5 parameters. One is R, which is called the reaction time. Another is K, or the K time, alpha angle, maximum amplitude, and lysis 30. If we understand all these 5 parameters, TEG becomes very easy to us. So now the first parameter, what is R time? R time is the time elapsed till the first measurable clot forms. So basically it is the time for the onset of the starting of coagulation. It simply is impacted by coagulation factors. So if there is any problem in reaction time, like the normal reaction time is 5 to 10 minutes. So if it is prolonged, if you are having a higher reaction time, that means it is taking time for clot to form and it is due to deficiency of clotting factor.
I think we have lost Dr. Madhur. I think there is some problem with this internet connection.
Take a standard fixed length of the clot, which is 20 mm. So when it is that time, yes, sir.
No, please go ahead. You were lost in between. Now you're back. Hello, Dr. Madhur.
Dr. Madhur, are you there?
I think his internet is unstable.
Yes, sir. The same I.
Because it's describing a very important thing, you know, that many people don't know it. So,
So I think I request Dr. Richa, because she is well versed about the situation, that what he left, what Dr. Madhur left, and I think Dr. Richa is very well can explain. Oh, Dr. Madhur is back. Dr. Madhur, can you hear us?
Dr. Madhur is back.
Yes, sir.
Can
Please
you start?
share again.
Dr. Madhur, there was some loss of connection. Now you are back. Yes.
So, madam, I think I was on the K time.
Yes.
So it's the time elapsed until the clot.
Madhur, I think you go back one slide.
All right. So our time is the reaction time. It is a time elapsed till the first measurable clot forms. If this time is prolonged, the limit is 5 to 10 minutes. If this time is more than 10 minutes, it means that there is clotting factor deficiency. And if there is deficiency of coagulation factors, what do we give? We give fresh frozen plasma to the patient. Then there is K time. We take a standard of 20 mm clot strength. We say that till the time clot starts forming and the time required to reach K time increases, it means the rate of clot formation is not adequate. If it increases, that tells us that it is due to deficiency of fibrinogen. What do? We give cryoprecipitate. Cryoprecipitate has 20 times more fibrinogen than the normal FFP. So that is our best choice, is the most fibrinogen rich compound blood component present. So we give fibrinogen to these patients. So now what is alpha angle? Alpha angle reflects the speed of fibrin accumulation. It is just a tangent which is drawn when the clot strength reaches 2 mm. So if you draw a tangent from start of the clotting factor to the strength of 2 mm and measure this angle with the x-axis, this is called an alpha angle. Normal alpha angle is 53 to 72 degrees. And if this alpha angle decreases, it means the clot is not reaching our strength very well. The amplitude will also be less later on. So this is because there is deficiency of fibrinogen. And like we mentioned in the last slide, what do we give for fibrinogen? We give cryoprecipitates for fibrinogen because it is the most fibrinogen-rich compound that we have. Now, talking about the maximum amplitude, it is the highest vertical amplitude of the tracing. We know that this time the clot has the maximum tensile strength. The clot is the strongest at maximum amplitude. And if we remember, the platelets were playing the major role right from the beginning. The clot cannot reach its maximum strength if the platelet is not there or platelets are not having their functions proper. So they are impacted by platelets. Normal maximum amplitude is 50 to 70 millimeters. So if this amplitude is decreased, we know that there is some coagulation problem, which is because of platelets, either because of the number of platelets or because of the platelet function. So the treatment we offer is platelets. It can be according to single donor platelet or normal platelets, which we have according to the condition or severity of the condition. Now there is another component or another parameter, which we call as lysis 30. This is nothing but just the percentage of amplitude reduction 30 minutes after maximum amplitude. So when the clot reaches maximum amplitude or maximum strength, what happens 30 minutes later to it? Because by this time, the fibrinolysis is there, the clot is started to decrease in strength. And this is a measure of the fibrinolysis, which is a normal process. But in case where there is hyperfibrinolysis, it means the lysis 30 times will increase. It means that we have to give antifibrinolytics like aminocaproic acid or tranexamic acid, which is very much used in the trauma settings. We give tranexamic acids in these cases. So now at the end, we've talked about R time, K time, alpha angle, maximum amplitude, and lysis 30. How does it extrapolate to ROTEM? ROTEM and TEG are one of the same things. The nomenclature is just different. While calculating R time in TAG, we should see that it is nothing but CT in ROTEM. And the treatment deficiency causes clotting factors. Treatments are fresh frozen plasma, like we discussed. K time is equal to clot firmness time. So this is the time the clot becomes firm, exactly the same as the K time, only the nomenclature is different. Deficiency of fibrinogen. The most fibrinogen-rich substance we have is cryoprecipitate. Alpha angle gives the rate. It is the same alpha angle in ROTEM as well, and the treatment is the deficiency of fibrinogen is there, and we give cryoprecipitate for it. Maximum amplitude is maximum clot firmness in ROTEM. Deficiency of platelets is there, and naturally we give platelets for the treatment. Lysis 30 is just LI, lytic index 30 in ROTEM, and deficiency of anti-fibrinolytic agents and tranexamic acids and amicar are given as a treatment for these things. So coming to the bird's eye view, if we see the tracing A, there is a reaction time, there's an alpha angle, clot reaches maximum amplitude. After some time, it goes down to lysis is there, and it's a normal thing. When we see a prolonged reaction time, we realize that the reaction time is more. There is coagulopathy, yes, but this patient might be on heparin or warfarin, which decreases the coagulation of factors, which acts on the coagulation factors, and thus we realize that coagulopathy is due to this reason. When we see that the amplitude is very less, just by a bird's eye view look, without even checking, we can see that the amplitude is less. This is because of platelet dysfunction, and we exactly immediately it comes into mind that we need to give platelets for this patient. And when we see that hyperfibrinolysis is there, suddenly there's a dip from maximum amplitude and reaches minimum, we realize that we need to give tranexamic acid to this patient, and we do that. Otherwise, if we see that the maximum amplitude is much more, these are hypercoagulable states. In trauma, DIC can be of both the types. Once, when there is intravascular thrombus, the sample has been taken from that part where there is thrombosis, we'll get the second tracing, where the amplitude is very high, alpha angle is high. While in the third part, in DIC, where already the consumption coagulopathy is there, platelets have been utilized elsewhere. Now there are no platelets in the sample which you have taken for the TEG or ROTEM. We see that the amplitude is very less. It's a very weak TEG. So at the end, all I want to say that if we confuse ourselves with the details, it's going to be very difficult. But for interpretation of TEG in ICU, we need only these 5 parameters. The interpretation into ROTEM is very simple. And this is my presentation on viscoelastics interpretation in ICU. Thank you.
Thank you very much, Dr. Madhur, for that lucid presentation. And what is, you have made the concept very clear. I remember in ICCON I presented the ACOTS, and many people are not able to understand. But now the way you have presented it really is, it's great. I think many of us who are attending directly have also gained perspective how to teach. Sometimes we may be a teacher, but may not be a good teacher in this respect. Thank you very much. I can't see any questions and answers, and I hand it over back to Dr. Dinesh for further proceedings.
Thank you very much, Professor Girish and Professor Richa, for conducting such a very critical session, I would say, as far as the education of surgical critical care is concerned. And before concluding the session, I would like to have quick comments from Dr. Richa about what should be the importance of learning basics of critical care as far as a trauma surgeon is concerned. Ma'am.
Thank you, Dr. Dinesh.
Ma'am, you are mute. Ma'am, you are mute. Please unmute yourself.
Thank you, Dr. Dinesh. First, I would like to thank the organizers for having me here and giving me the opportunity to be a part of this extravaganza of information. Secondly, the Madhu's talk was excellent. I would like to add one thing in the Madhu's talk, that yes, we are interpreting the TEG and ROTEM values, but in a patient who is bleeding, who is a trauma patient, these values, they keep on changing very rapidly. So we have to be very cautious while we are seeing the values of TEG and giving the treatment. As the patient is bleeding, he is losing coagulation factors, platelets, and these values, they may show different at different times. Thirdly, it is very important to know from surgeon's perspective, the critical care issues, because then we can work in a cooperative manner. We come to know what are the surgeon's issue, and the surgeons, they come to know what are the critical care issues, and the patient will benefit all in all. Right. Thank you very much for such a nice session.
Thank you once again, and I extend my greetings on behalf of organizing committee of STEC to all the faculties and chairperson for devoting their time, I would say, to the learning of delegates. And just to make a note, all the 3 speakers, they are very much alumni of AIIMS Trauma Center New Delhi, and we are proud of them. They are the leader at the trauma services at their respective institutes. Thank you, sir. Thank you very much, Dr. Girish and Dr. Richa.
Thank you.
And we conclude the session here. So now we move on the next session, and the next session is a unconventional session, I would say, because you will not encounter such a session in conventional medical conferences. And the session is all about MILAP. So what is MILAP? I hope my slides are visible. Can someone?
Yes, your slides are visible, Dinesh.
Okay. Thank you, ma'am. Thank you, ma'am.
First, would you like to introduce all the people on dais, or you want to?
No, ma'am. I would introduce first MILAP, and then we will one by one we will introduce our MILAP site in charges.
Fine. Please carry on.
So, what is MILAP? So, if we threadbare the MILAP in our Rashtra Bhasha, it is all about sitting together, working together, meeting with our family and friends, working together, sharing our good and accolades with them, and sharing our failure with them, and try to kind of console to each other. And so same philosophy our leadership at JPNATC realized, and they decided to have a common platform where the upbringing, the new formulating the trauma faculty, trauma family, they can meet regularly and they can learn from each other. So with the same concept, they constituted this online platform called MILAP. The full form is Multi-Institutional Learning and Practice. All the budding new institutes who are running trauma services, they can be all together, they can share their ideas, they can learn from each other. It's a purely academic session, and we just have words about what we have learned so far, what we are learning, how we can improve our learning, what we have done, and if there are any kind of shortcomings, how we can take care of that. There is no financial involvement because this is just a friendly and family gesture, and it is being done with permission from the competent authority, and it is kind of confidential. Though today we are doing it in a open platform, but otherwise the MILAP sessions, they are a closed group session, and whatever happens in the Vegas stays in the Vegas. So the very first session was on 5th September 2019, where our own Professor Amit Gupta sir, who just delivered the very, I would say, premier oration, Donald Trump oration. I need not to give to our listeners that who is the Donald Trump. And on the name of that oration, he gave that the challenges in the development of the trauma systems in an emerging economy like India. And he kindly agreed to deliver the same oration in the very first session of the MILAP, which happened on 5th September 2019. At that time, the Zoom was not in picture. So we used to have the NRC, National Medical College platform, and we used to have telecast on that. But these are the few pictures from the preceding sessions we have conducted, where the visiting faculties and our own faculties give us about idea. The few remarkable sessions we had about the blunt trauma chest management from AIIMS Rishikesh, the pancreatic trauma management from the KGMU Lucknow, and one of the visiting faculty from Japan. They gave us a very comprehensive idea about the concept of the hybrid OR. And then the COVID came into the place, but we didn't stop. And at that time, we had a RIBOA workshop, that is the resuscitative endovascular balloon occlusion of the aorta, live session with the Örebro University, Sweden. Though we are not yet having RIBOA in our country, but again, this workshop and further collaboration are in process so that we can introduce this modality also in our country. So what is the future vision of the MILAP? It is the collaboration, together teaching, turning, sharing research ideas and collaboration for the research, sharing knowledge from each other, patient care, and ultimately the quality improvement. So to begin with, we were having few institutes, but as our family is growing, so we welcome our new member institutes. So this is all about overview of what is the MILAP. And now I request the interesting case presentation from all the partner institutes, to begin with the AIIMS Delhi, where Dr. Preksha will be discussing a interesting case. Over to Dr. Preksha. Dr. Preksha, please share your slide and start your presentation. At the same time, I would request all the faculty and residents who are presenting to take care of the time limits too. We don't want to lingering on. Tech team, please allow Dr. Preksha.
Good afternoon, everyone. I hope I'm visible and my slide is also visible.
Yes.
I'm Dr. Preksha Rani, SIMCS training from the Division of Trauma Surgery and Critical Care at JPNATC AIIMS Delhi. I'll be discussing the case medical conundrums do not deter from our protocols. We had a 21-year male with an alleged history of road traffic injury. A motorized helmeted two-wheeler rider hit by a four-wheeler who arrived to us 1 hour post-injury was brought by a bystander. On primary survey, his airway was patent, cervical spine stabilized. He was tachypneic with a rate of 22 per minute and saturation of 96%. On the left side, the air entry was decreased, test compression test was positive. He had a 3 into 2 centimeter muzzle deep wound in the intraclavicular location with surrounding hematoma. He was in class 4 shock with a tachycardia of 120 per minute and a BP of 88/66 millimeters mercury with the GCS of full score. His etchings EFAS was positive in the left pleural space, for which left ICD was inserted. There was which drained 2.5 liters of fresh blood. His pelvic X-ray was normal. Even his ABG showed high lactates of 7.5 and poor base deficits. In view of massive thorax and even with Cristal infusion poor not improvement of vitals, he was declared a non-responder. What do we do next? We continued along the line of damage control resuscitation, limiting the crystalloid infusion, massive hemorrhagic protocol activation, early blood products transfusion, tranexamic acid was given, and early hemorrhage control, for which rush to OR stat. In the OT, we did a damage control left anterolateral thoracotomy. There we found gross hemothorax of about 1 liter fresh blood in the pleural cavity. There was active bleeding from the left internal mammary artery at the level of second rib, which was ligated. There were displaced fractures of the second and third rib and a laceration in the apical lobe of the left lung, which was 2 into 2 centimeter with no active air leak. After ligating the left internal mammary artery, we placed the ICDs up and closing the wound, he was shifted to ICU. There we continued with the resuscitation with thromboelastography with blood products. Patient was improving, his M status was M6, even his oxygenation and ABG was improved, tachycardia was settling, his urine output was adequate, but patient remained hypotensive with the non-invasive bilateral upper limb map less than 65. As we couldn't continue with the secondary survey in the ED, so after shifting the patient in the ICU and stabilizing, we continued with the secondary survey, which the protocols dictate. In secondary survey, we found disparity in the bilateral upper and lower limb pulses. All limbs were warm, the saturation of 100%, and there was no neurological deficits, power of 5/5. But the bilateral upper limb pulses, brachial, radial, ulna, were not palpable, and bilateral lower limb, all pulses were palpable. There was no significant ample history. This was baffling to us, bilateral upper limbs. We thought about what could be the cause. Considering in the setting of trauma-related, he was improving in the vitals. The impact of trauma was mainly left-sided. There were no rib fractures or any skeletal fracture on the right side. Bilateral limbs were viable and functional. So a unilateral vascular injury could be a possibility, but a bilateral vascular injury seemed less likely to us. We thought possibly the patient may be having some pre-existing medical or surgical disease. The searching literature, there were possibility of a bilateral subclavian artery stenosis, bilateral thoracic outlet syndrome, or even a Takayasu arthritis of bilateral upper limbs, but all these were itself rare etiologies. We thought, let's continue with the secondary survey and go ahead with the imaging and adding the sequences with respect to our clinical findings. There, N60 head, C-spine was normal. His torso showed manubrium sterni fracture, left clavicular fracture, left second and third rib fractures, and hemothorax with ICDs in C2. His bilateral upper limb CT angiographies, the findings were astonishing to us. Right-sided, there was a right subclavian artery injury. It was a dissection with an intimal flap of 1 centimeter distal to the origin, and even a left-sided subclavian artery injury. This was a thrombus of about 4 centimeter from second part of left subclavian to second part of left axillary with a good distal collateral flow. We had challenges ahead of us. Here we had a patient in the class 4 shock who's going ongoing resuscitation. He has received massive blood products with the risk of its own complications, risk of coagulopathy. He had eye injury severity scores indicating the magnitude of severe trauma. Now we had bilateral upper limb peripheral vascular injuries and the risk of ischemia in the bilateral upper limbs. How do we manage? For the right subclavian artery injury, it's a dominant limb. There's a dissection on the right side, and there is proximal subclavian artery injury. In these cases, operative intervention would require difficult access. So we plan to go ahead with minimal invasive techniques. We'll discuss with our interventional radiology team and plan for endovascular stenting. We have done many cases with our team and had favorable outcomes. So this seemed feasible to us in our setup. For the left subclavian artery injury, it was a thrombus with distal good reformation. Even the limb was viable and functional, no signs of ischemia, and about 24 hours post-injury, with the patient still recovering from his first surgery. We plan to go ahead with the non-operative on the left side. He was shifted to angio suite. On catheterization, we found the right subclavian dissection was proximal to the origin. Here, to achieve precision of the stent, to avoid the common carotid artery occlusion, balloon-mounted stent for use. And here we can smooth after the stent was deployed. We can see the entire patent system. Even on the left angio, which shows a good collateral network on the left side with the distal reformation. So this was good finding to know for the left side. Here we can see the stent in situ with a good flow. Post-operatively, patient did well. His right-sided upper limb was warm. All the pulses were now palpable. Left-sided, there were no signs of ischemia, but the pulses were still not palpable. There was no neurological deficit in either limbs. Even the color Doppler was suggestive of the same. We discharged him on POT 12. In the follow-up after 4 weeks, patient, they had no clinical signs of ischemia in the bilateral upper limb, but the imaging was suggestive of the left subclavian. There was a thrombus segment with good distal reformation. Right side was an aneurysm. We could see the stent at the level of the stent placement. There was an aneurysm of about 1.3 centimeter. Now, this being a true aneurysm with no risk of imminent rupture of about 1 centimeter, we plan to keep him under observation with intensive follow-up. We repeated the imaging 3 weeks later. There we found that there was expansion in the size of the aneurysm at the level of the stent. And also we discussed with the radiology team. We found that the right vertebral artery, which should have been occluded by the stent, is now patent. It's receiving probably a supply from the contralateral vertebral artery via patent circle of Willis. So this, considering this is the cause of the aneurysm with a type 2 endoleak diagnosis, which was increasing in size, so sac expansion. And this was just proximal to the original subclavian artery, just 4 mm. So we considered for operative exploration. And this was discussed with the CTVS team. In the OT, subclavian artery aneurysm was resected and an interposition diaphragm graft was employed, endoside anastomosis. There, in the OT, a median sternotomy was done. We obtained the right common carotid and right brachiocephalic control was obtained proximally and distally. Then the subclavian artery proximally was looped, while separate axillary incision, the distal right axillary artery was controlled. Aneurysm was resected, and then the graft in situ. Post-operatively, patient did well. His entire right upper limb was warm. He had one episode of seizure and developed secondary features of Horner syndrome. We discussed this with the neurology team, and antiepileptics were started. Post-operatively, imaging also showed the right-sided patent system. Left-sided thrombosis was still present, but there was a good axillary reformation and distal flow. He was discharged 10 days post the surgery on antiplatelets and antiepileptics. What we learned from this case: the importance of secondary survey cannot be understated anywhere else, especially in an unresponsive or unstable patient. The potential for missing an injury or failing to appreciate the significance is great. Missed injury rates decreased by 35% with a good secondary survey. For subclavian artery injury, we couldn't find any literature on bilateral subclavian artery injury. The available data is on unilateral. Even that is rare and mainly associated with penetrating mechanisms. Coexistent internal mammary artery injuries is also rarely reported. The management of this case exemplified the importance of multidisciplinary approach, by which we could achieve a good outcome. Take-home messages: this patient reinforces the definition of trauma for us. The transfer of energy from the external to human body could lead to disfigurement of membranes, and that tissue plane disfigurement could be at far away from the site of impact. Trauma does not follow anatomical boundaries. Hence, a good secondary survey can lead to identify and a tertiary survey can lead to identify of all the injuries. Follow protocols, constant and vigilant monitoring can lead to favorable outcomes. Multidisciplinary approach can help optimize care, minimize morbidity and mortality. This is the only reported case of bilateral subclavian artery injury according to us. Thank you.
Thank you very much, Dr. Preksha. And now I open the discussion for the site in charges, if they have any question or comments to make, as it is a collective learning process. Dr. Vignesh, please unmute yourself first.
Yes, it was a very good case. Definitely shows that the ATLS principles and the importance of a primary survey, a secondary survey, and definitely a tertiary survey, where such injuries can be picked up even in patients who are initially non-responders and require some other form of treatment. My only question is for these left-sided subclavian artery. I just want to know how many cases that you've experienced recently of left subclavian or any subclavian artery injury where non-operative management is formed. Do they come back with any kind of deficits or neurological, some kind of claudication or anything like that?
So in my experience, we have seen about, especially mainly cases with who present late, They are but the viable limbs, so we have managed them non-operatively. On follow-ups, I can say I've seen in my period of experience of about 3 cases, and in follow-up, the limited follow-ups what they have had, there have been no signs of claudication or ischemia, and even we even repeat imaging and Dopplers where it shows a good outcome in the distal flow, though the thrombosis is still in situ. That's probably because of the good collateral network from the subclavian arc from the first part to the third part of axillary. That's why.
Yeah, yes, I agree. I think that's the same that I can say from my experience as well, that these patients do not develop any kind of claudication, which is why people think that they need some kind of intervention even if they present a little later. Some subclavian arteries, can be managed non-operatively, provided there is a good distal flow. Thank you.
So thank you very much, Vignesh. Any other comment from any other site in charges?
Dinesh, thank you. This is a nice teamwork. I will say you involve the intervention radiologists. You do this, then you follow the ATLS principle. Is any infarct in the later on in the case, this case? Because he had the seizure during the hospital stay.
Sir, when we did the final imaging for the post-operatively, even for the infarct, we got a CT angio of the head and neck also, included in the same setting. There was no signs of infarct in the imaging. And even there was no episode of any other seizure and no signs of any non-neurological deficits in the patient clinically.
Thanks.
So thank you very much, Dr. Preksha. And now we move on and to introduce our next site in charge from AIIMS Jodhpur. So we have very talented, very dynamic personality as a site in charge there, Dr. Mahavir Roda. He is kind of taking care of trauma facility there since inception. Presently, he is working with the responsibility of associate professor. So Dr. Mahavir, would you like to have few words to our delegates about the trauma services you are running at AIIMS Jodhpur?
My screen visual?
Yes, Dr. Mahavir, we can see the screen. You please move.
Hi. Good afternoon. Myself, Dr. Mahavir. I'm thanks to the organizer, especially Dr. Dinesh, my teacher and my mentor, Dr. Subodh, Dr. Amit Gupta, Dr. Susma, Dr. Viplav, and definitely Dr. M.C. Misra, to give this opportunity. I am a trained and from the AIIMS Delhi. My UG/PG I have seen the trauma from my beginning MBBS MSc days in Rajasthan, and I'm trained in the AIIMS Delhi Trauma Center, and I come back, so I can see a major change in the treating and handling of the trauma at this our center. The AIIMS Jodhpur started in the 2012 under PMMSY scheme, but the trauma center, the emergency and trauma center started in the late 2017, or we can say the 2018. So a brief about our presentation brief. I will about the trauma center in Jodhpur, and my resident Dr. Chaitanya will present that one. Special case which we treat in our center. So AIIMS Jodhpur is located in the Marwar region. It caters the whole Marwar region, the 5-6 district. The drainage area is the 5 to 6 district. Although Jodhpur have the state medical college, but many times I had the opportunity to see that center. But the treatment of the trauma care at this time is still like I have seen in my MS days in the 2005 or 2008, like the same trend is going on. So this is slightly difference in the from state medical college versus the state of art trauma center of the AIIMS Jodhpur. So everyone, I think, have seen the newspaper or in some social media there is a one OD, the hit the 2-3 vehicle, 2-3 people died, and it stuck in the slum area. So recently we saw a multiple casualty. In our capacity, we can say this is a mass casualty. So we can see this is the preparation. Many things of the ATLS principle followed in this one. The preparation, we got the information that a large population, a large crowd is coming. So the preparation in the arrival area, and this is the triage area and the treatment area. And this is the some simultaneously going with the treatment and the resuscitation according to the team. There is one more incidents happen in this area. In the bus and the truck, the accident, and the bus was burnt, and there around 15 people were died on the spot. And then we see the multiple patient or multiple people from that incident, and we manage accordingly as per the ATLS protocol. So the volume of the trauma center, so the total footfall of the last year, last year is the 24,248 patients we received total, including the medical and surgical patient, and out of that surgical patient were 8,611. In the out of 8,600, the trauma patient was the 3,100, around 27% all surgical emergency were the trauma emergency. So I will say this is the as per load, this is the high volume center of the our trauma center is the high volume center according to our the inflow of the emergencies. So in view of the academics, we started the MCS program 1 year back, although it was approved earlier. So we have the 2 per session, it means 4 seats per year. Currently we have the 2 residents, Dr. Chaitanya and Dr. Milind, 2 residents are there, and the first 2 candidates are there. And this December, January batch, we are expecting the 4 more. We also started because this is the combined trauma and emergency. When we combine emergency medicine, MD program is also started. That's the 4 students per year. It means 2 candidates per session. So the 3 batches are currently in place. So the AIM Jodhpur is the recognized center for the ATLS, and the ATLS currently we start the addition program. We conducted the 5th ATLS program just last month, and the first course of the inauguration course of the addition also. And we conducted one IP course also. To improve the quality, we regularly do the quality improvement meeting with the faculty, resident, inter-departmental, and we discuss the post-treatment. We discuss the anonymously the cases where we can improve our services or other things. These are the glimpse of the few cases where we from the head to toe, from there's a tracheobronchial injury case, cardiac injury case. This is some reduction chest for the entering of the lung chest. This is the pancreatic injury case, the vascular injury case. This is a massive degloving injury case. We manage at our center. So in future, what we are going to include in our the system is the trauma. This is the trauma care is the dynamic one, and we can improve with the time, and we will. There is a planning to start the separate trauma block. It is in pipeline. It is in the administrative one that we will create the 250 or 350 separate trauma block or trauma the building. And the liaising of the other department for the outreach programs, and to train the other people also of this area. That's also an important one. Like in India, the pre-hospital, the first responder one, we are doing it, and with a small scale, but we will escalate with the time once we have some permission from the state, and we are on that pace. And important one, the school, the other people like the layman people, the school children, and the involvement. This is going on this is on pipeline, and we will do shortly, and will convey to the society, the appropriate form. I'm inviting my resident, Dr. Chaitanya. He will present one Dr. Chaitanya.
Good afternoon all. Myself, Dr. Chaitanya, academic expert, trauma surgery and critical care, AIIMS Jodhpur. Today for my lab, I'm presenting a case titled Refixation for a non-flail chest. Content would be objectives, case, discussion, and summary. Coming to introduction, incidence of rib fracture varies between 7 and 40% of all trauma patients, depending on the study done. Surgical fixation of ribs has 0.7% point prevalence in a flail chest, which was taken from a paper quantifying and exploring the recent national increase in SSRF by Erica Kane. Traditionally, rib fractures are managed non-operatively or supportively, which include systemic, locoregional pain management, proper pulmonary hygiene, in extreme cases by mechanical ventilation. Rationally for this is that intact rib cage will allow the callus to be formed. Last decade showed growing interest and research, and also newer rib fixation devices come into the market and play. So far, the limited data suggests decreased pleural space complications and decreased pain. So, coming to the case, it's a 40-year-old male. Biker hit with a moving truck. He had a blunt chest injury with suspected head injury. His signs were BP was 120/64, respiratory rate 28 per minute, pulse rate 84, saturation was 95% on room med. Primary survey showed patient was airway was patent, no cervical spine tenderness. Breathing spontaneous with bilateral surgical emphysema, saturation 95%, respiratory rate 28 per minute. Chest compression test was positive, decreased air entry on right side, Krebs were present. In view of these findings, right side ICD was immediately placed. Circulation was BP was 118/64, pulse rate 74, pelvic compression was negative. His GCS was E4, V4, M6, patient was slightly drowsy, pupils were equal and reactive to light. Apart from this, large area of bruising was seen at the posterior axillary line and lower chest and posterior flank. EFAS was done. It was positive in the pleural window. Initial chest radiography shows from outside to inside. Right surgical emphysema extending up till the neck. Right clavicle lateral third fracture. Multiple contiguous rib fractures seen with right hemothorax. Right with hemothorax with ICD in situ. CT brain was done for a suspected head injury. Patient showed hemorrhagic contusions with a mild SAH and SDH component here in the left frontotemporal parietal region, and subgleal hematoma was seen on the bilateral side. This is an axial section of the CT chest that was done. It shows that the patient had a pneumothorax and has a hemothorax and a displaced rib fractures with surgical emphysema on the right side, extensive surgical emphysema on the right side with ICD in situ. Another section showing that there is a underlying pulmonary contusion. This is an axial bone window. This is the volume rendered picture projection, which shows that 2nd to 9th rib fractures were done. 2 to 7 were lateral and 8 and 9 posterior. Course in the hospital, the patient was drowsy and in due course improved GCS to full. ICD was removed on day 2, but the patient had a persistent surgical emphysema and his visual analog pain score was 7 on day 6. So hence the CT was reviewed with radiologist. Again, the it was told that there was impingement of lung by fractured rib. Surgery was planned for fixation with due consent on 8th post-op day. The plan was discussed in detail with the patient and attendants in terms of outcomes and expectations. These are the operative pictures. Under GA, the patient was under GA with double lung ventilation. The patient was placed in a lateral decubitus position. Landmarks were marked. Curvilinear incision was done over the 5th rib. The fractures were reduced with the help of bone holding forceps and aligned, and the width of the rib were measured with the caliper, and appropriate screw was placed. So you can see that in the last image, the rib plates were not visible. It was closed with 10 vicryl, and a new ICD was placed. The new ICD was placed, and it was removed on the second post of it. This is a immediate post of X-ray, which shows that the deformity of the rib fractures have been aligned. There is no rib deformity as such. This is the pre-operative picture, which shows that there is a clear deformity of the thoracic cage. Patient discharged within a week after surgery in stable condition. Patient is followed up continuously after a month and after 2 months presently. These are the follow-up pictures. The scar has healed well. And this is his X-ray on 5th October. The patient's, you can see that there is a new callus formation in the non-fixed ribs, and the patient lung expansion has increased, and the patient subjectively tells that his pain has been decreased. Coming to the discussion part, potential indications of rib fractures, they can be plial chest, which is indicated especially. Other indications could be chest wall deformity or defect for reducing pain and disability, symptomatic rib fractures or non-union chronically after 2 months, or on way out or a drive-by. This is an algorithm from Chest Wall Injuries Society. It shows that rib fractures initially has to be managed with the CT chest, assess respiratory function, multimodal pain control, locoregional pain therapy. If the patient has shock or ongoing resuscitation, severe TBI, acute MI, or outside the rib fractures such as 3 to 10. 3 to 10 are amenable to fixation. Then if it is yes, then it is a non-operative management. If no, there is a chest wall instability, yes or no. Yes, if there is no any other high priority injuries. Otherwise, you can do a less than 72 hours, you can operate. But you can see here, any patient on a ventilator and a failure to wean due to rib fractures, it is an absolute indication for fixation. Coming to review of literature, there have been some popular studies that have been cited by many textbooks. Fagvik Olson et al. He has told in terms of physical function and also the thoracic range of movements that improved after 2 weeks. And Pirachi et al. He's also did a study, and he's also doing this. He's a principal investigator of Chest Wall Injury Society non-trial trial, of which he also shows that there is a decreased NPS at 2 weeks and level 2 thoracic indicators. Future directions: increase in popularity, but clearly underutilized procedure. Training of residents and surgeons in the technique of rib fracture has to be done. In need of consensus guidelines, more RCT is necessary for data. Minimal invasive techniques can be developed. Coming to any suggestions or any questions?
Thank you very much, Dr. Chaitanya. So now I open the house for other faculties if they have any comment and questions or their own experience to share about this procedure.
Yeah, I would like to this very pertinent question related to the for flail segment. We are doing the fixation, but for a non-flail, you have opened a new window. My only question is, why did you take the late decision? Like, say, after 8 days, planning to go for operative fixation. The multiple study has showed that the planning to fix the rib should be taken within 72 hours of injury or admission.
Especially in this case, the patient had a traumatic brain injury. The patient, it took some time for the patient to have Jesus improved. And coming to the timing of the surgery, the under 72 hours was done, but it is still a limited data that does not show much improvement. It's a level 5 data. So in our case, because we were waiting for the patient to get a GCS improved,
Thank you. Thank you, Dr. Chaitanya, for your kind comment. And thank you very much, Dr. Mahavir, for your lucid presentation about the trauma services at AIIMS Jodhpur and your future direction. I am pretty sure that many new budding our trauma surgeon, they are going to get benefit from your vast experience about your clinical services as well as the administrative services and development of trauma system further. Thank you very much.
Thank you, Dr. Dinesh. Definitely, thanks. And if any help we need, we will contact you.
Thank you. So we move on, and our next Milap site in charge is the newly joined site that is from AIIMS Nagpur, and our own alumni, Dr. Soumya, had just joined there as assistant professor in the leadership of actually there, Dr. Siddharth, and he is kind of given responsibility to develop trauma services from scratches. And Dr. Soumya is going to share with us few ideas about what is in mind as far as the future vision is concerned, though they have not started the full-blown trauma services there. So we won't be having, as of now, their share from their trauma management experience, but definitely their vision is going to help us. Dr. Soumya, over to you.
My screen is visible, sir?
Yes. Dr. Soumya, you can move on.
Again, a very good afternoon to my respected teachers, my juniors, my colleagues. I am glad and honored to represent AIIMS Nagpur in this special occasion of Milap. Unfortunately, our mentor, the head of the department, Dr. Professor Dubhashi, is unable to physically be present due to some prior commitment, but I feel myself to be fortunate enough that I got a chance to speak on his behalf. Welcome to AIIMS Nagpur. This is our mission statement. The words has been created by the very own mind of Professor Dubhashi to nurture a vibrant academic platform with a scientific temper, thereby creating leaders in surgical education with a spirit of innovation and inquiry, with provision of comprehensive, cost-effective, patient-centered quality healthcare. This is our motto. Our motto is education, innovation, and heal. This is a continuous process. This is our whole team under the guidance of Professor Dubhashi, and this team is giving their 100% effort to take our institution to the next level. But we have fixed our gaze to another target, to build a robust trauma system. 3 pillars which we identified to achieve our goals are infrastructure and training, academics, and research. We have an inpatient department which includes almost 690 beds. We have a 24 hours running emergency department which are capable of catering most severely acutely injured trauma patients. By academics, we are committed to create knowledge by nurturing the knowledge creator. And we are also looking forward to the research activities, both institutional and multi-institutional, with collaboration with other medical institutes. Our focus in next few days will be to gather data. Right now, I don't have any data, but our focus is to gather data and to make a hospital-based injury surveillance system, and also to create and maintain a trauma registry. And obviously for this, we need a continuous support and motivation from my mentor from the Apex Institution of Trauma in New Delhi. Professor Dubhashi is a very passionate teacher. His vision is to create a learning trauma system. We actually envisioned that sowing the seeds of evidence-based trauma management protocols in the mind of budding doctors at a very early stage is very helpful to develop a learning healthcare system in future. So the ultimate vision is to make a trauma system which is a continuously learning healthcare system. So for this goal to achieve, we are focusing to these mainly 4 aspects. that is undergraduate and postgraduate training, research projects, and training of the teachers program, so that to achieve the ultimate goal is to provide the state-of-art comprehensive quality trauma care to all acutely injured patients from resuscitation to rehabilitation. Thank you.
Thank you. Thank you very much, Dr. Soumya, for sharing with us your future vision. And for a lighter note, you can call all your colleagues for helping you. And in case someone is not responding, you know very well whom to call. So that's all. If any comment from your colleagues and any seniors, welcome.
Sir, it was very good to see all the people here, all my mentor teachers. Thank you for your continuous support. I think
Professor Sushma, our mentor, is also there. Professor Sushma, ma'am, if you are available, can you make a quick comment to guide Dr. Soumya? Okay, so I think ma'am is busy with other tasks. So, okay, now we move on and we welcome our next AIMS Patna site in charge, Dr. Majid. Dr. Majid, again, our own alumni, and presently is the leader there for developing of trauma services. Dr. Majid, stage is all yours.
Good afternoon, sir. I introduce about our new center, AIMS Trauma Center, which has been running for last 2 to 3 years, but due to the COVID pandemic and the
Dr. AIMS, Dr. Majid,
acute
if you
shortage.
have any slide to share, because we are not seeing any slides. If you have any slide, please share, or you are just describing us your verbal communication.
Is it visible, sir?
Not yet.
Just wait.
Sir, no issues, no issues. I think there must be some technical issues.
Not getting
you can give us an idea about
yes,
your
sir.
vision.
So ours is a new trauma center. AIMS Patna was built in 2012, and the trauma center came into being on 2018. We have got a 4-story building, and we are particularly catering to the trauma patient and emergency services. And after the COVID pandemic, we are taking lots of neurotrauma, emergency surgery, and we have started training program in trauma surgery and critical care. We have got a bunch of orthopedic surgeon, neurosurgeon, and general surgery. They're all working in the department, and we are trying to develop a trauma care. Actually, Bihar is a very undeveloped part of India, particularly, and the comprehensive trauma management is very much lacking in this part of the region. Most of the patients, they either come late because of non-transfer, or sometime if they are getting transferred, they are coming at a very late stage. So it's very difficult for us to establish a trauma center considering the resources and the number of patients, which is quite high. We have to regret a lot of patients on a daily basis. So it's sometimes it's very painful for us also. And we have got MCS trauma surgery and critical care course. However, in the last session, because of the COVID, one of our residents, he got shifted to AIIMS Jodhpur. So we are running short of hands also. So we have got in the next session probably we will have enough number of person to cater to our trauma services. That's it, and we would be looking for all the valuable suggestion, comments.
Thank you, Dr. Majid. Do you want to share some experience of trauma management with us?
Yes, sir. My resident, I think he has joined.
No, I think he has not joined. So till the time he join, we can move on. And definitely, we can very well understand about the kind of difficulties you are facing. But that is the trauma management is all about. That you always have to face difficulty, but still you have to keep your spirit high and fight it. So thank you very much. If the resident is able to join, we will have the case discussion from him. Till the time we move on with our next site in charge, and probably one of the most established trauma service management system is there, and not other than Dr. Ajay Kumar, who is presently working as associate professor in the Department of Trauma Surgery at AIIMS Rishikesh. And I think Dr. Ajay will be the best person to show us that what they have got and what they want to. Dr. Ajay, all yours.
Thank you, sir. And I want to like to thank our mentors, Dr. Subodh sir and Dr. Susma Sagar. And I'd like to thank the ISTAC and Trauma 2021 for giving us an opportunity to present and our aims and our future plannings. So I'd like to share my screen first. Is my screen is visible?
Yes, sir, visible.
Yeah. So once again, I'd like to welcome you all from AIIMS Rishikesh. Our AIIMS Rishikesh is just in the foothills of Himalaya, and we have a wonderful trauma center here. And our history starts from May 2017, when Trauma Center, or you can say the system of trauma, started with emergency department. Later on November 2019, we shifted to our trauma building. This is our trauma building. In the background, you can see. And we have a full-fledged trauma center here with our mission to render a timely care of international standards to trauma victims. And our vision is to give an excellent academic and educational milieu for teaching, training, and research. And we always give priorities for social awareness and participation of the society into the trauma system. We at the Trauma Center, AIIMS Rishikesh, work with the objective of providing all the patients with world-class trauma care. And we are committed for a better and international level of trauma care. Here at our Trauma Center, we have, at present, we have 4 consultants, but previously we used to have 8 consultants. Now most of them have, because of some issues, most of people have left, but more people are going to join. We have MCS students. At present, we have 7, and it's also sometimes we used to have 9. Now we have 7. 2 of our trauma residents are going in the exams. We have orthopedic residents also in our trauma center. We also give space for the residents from general surgery, and they come on rotation basis. We have a totally dedicated trauma ICU of 14 beds, which can be increased to 20 beds, but still we are managing with 14 beds. We have a trauma ward, general ward of 30 beds with a disaster ward of 20 beds, which are usually 50% of them are used to kept empty, and 50% are being used as a buffer beds. When we don't have beds in our wards, we used to keep the patients there. We have a round-the-clock trauma OT dedicated to trauma. It is different from what emergency department emergency OT is there. We have a 24/7 emergency OT and 24/7 trauma OT. We used to run daily trauma OPD in trauma center itself, and an orthopedic OPD also in the trauma center. We also run special clinics for sports injury, spine injury, vascular surgery, thoracic surgery, and also we have started amputation clinics. These are the few activities what we do on regular basis. Like we do a thesis update of our residents. We do topic presentations on different topics. We used to do general clubs by our residents. And one of the important things, we do a coffee with consultant, which is a new concept where we used to call consultants from various departments in our institute, our department, to share their views. We do on Saturdays, we do department meetings and also mortality and morbidity presentations. And on Saturday also, we used to do Action, which is an international general club in which most of the centers of the UK, US, Israel, and Australia, these centers have been incorporated in this Action group, and we used to do that on regular basis. We have the 3 levels of in our trauma center. In level 1, we have a trauma ED with OT complex, lab, and everything in the ground floor itself. In the level 2, we have ward complex, general wards, private wards, HDU, disaster wards. In level 3, we have another set of OT. These are set for elective OTs. We have ICU complex on level 3, blood bank, and central pharmacies. We give level 1 trauma care to our patients with ATLS protocol and further definitive management by evidence-based medicines. We do regular workshops and conferences. These are the few pics of those workshops. We used to do World Trauma Day. On every World Trauma Day, we used to do some social activities by Nukkal Natak and various other activities. This is our helipad, which is the only center with helipad in its own campus, being in which last month our Honorable Prime Minister also visited our helipad. And our future plannings are to build hyperbaric OTs. We have been given opportunity to develop a Center of Excellence in Trauma by Ministry of Health, and we are also bringing some new courses like PDCC courses in acute care surgery. We are also working on nursing training, and we have already given up approval for MSc in trauma care nursing and other training programs also. And by like this, I would like to thank you all. And after my presentation, our senior resident, Dr. Ruby Kataria, is going to present an interesting case of
Thank you, Dr. Ajay. And I request you and our senior resident, Dr. Ruby, to please make it quick because we are already running short of time. So it would be better that if we take all the inputs from all the faculties, so that the ethos of Milap keep going. Dr. Ruby, please make it quick. Dr. Ruby?
Yes, sir. So my site
please.
is visible?
Yes, site are visible. Make it full screen.
Okay, sir. I'll take care of, definitely I'll keep this in mind. A very warm welcome to all of you. From Rishikesh, my greetings from James Rishikesh. I'll be presenting an interesting case of the blunt cardiac rupture. Starting with an introduction point that...
Ruby, please make it on full screen. We are just showing slide.
Okay, sir. Okay.
Open the camera.
Yes, and please open the camera.
Just a second, sir. Yeah. Starting with that patient with in the road traffic injury, the thoracic trauma, but shares a rate of 25% death occurs due to road traffic injury. Thoracic trauma pertain 25% share. Then out of which these 25%, 10 to 70% are shared by blunt cardiac ruptures. So most of the time, the mechanism or the mode of the injury remains to be the frontal contusion that leads to the cardiac rupture. And the atrial ruptures are more common in blunt. There can be a penetrating injury and blunt picture also, but specifically when talking about the blunt cardiac rupture, the atrial ruptures are more common. And the more site in the are that SVC atrial junction, IVC atrial junction, and the right atrial appendages. Post-operatively, when we operate such patients and those who survive, they landed up into the pneumonia or sepsis. They are associated with the polytrauma, and this leads to the worsened prognosis. Even after managing such patients, operating them, they further landed up into the ARDS on sepsis and have a very bad prognosis. And usually they are associated with the high mortality. Most of them do not reach at the time or if they reach at a time, they have this. Then when we received this patient, this is a 25-year-old male who had a motor vehicle collision, an unstrained truck driver. He sustained a blunt trauma chest from the steering wheel. On presentation, he has a tachycardia of 154 per minute. His blood pressure is 100/62, respiratory is 28. And very interestingly, they have given a reference slip. They have very well mentioned that there is an engorged neck veins, but still no intervention has been done for the things which we come to the mind when we have such a presentation, that engorged neck veins are there. Still, they have referred the patient to us, and he presented to us after 4 hours after the injury. On presentation, patient airway was patent, C-space was stabilized, air entry was reduced on the left side, as saturation he was maintaining of 99%, but his chest compression test was positive. Heart rate is same, 150 per minute, but BP has dropped down to the 80/40, and when we did the fast, the pericardial fluid was there. Along with that, there's this minimal fluid in the left hemothorax. GCS, he was E4, V5, M6, pupil is bilateral normal, there is no sign suggestive of any head injuries, and hypothermia is prevented. So when we find out there are other associated injuries are like right open tibia fracture is there, which is with compartment syndrome, and fast there is a cardiac tamponade. Then immediately cardiosynthesis was done. 100 ml of blood was drained from that, and we still left that we have used the 16 French catheter, and we have left that catheter into the cavity. And left side ICD was done. The 200 ml of blood was drained. Once the patient was stabilized, still the patient BP was low. We have taken the patient for the CTA, which was suggestive of there is a small fluid left in the pericardium, but still the blood is present. Then there is no active contrast extravasation leak was there, but as there is a hemo pericardium is there, we have taken the patient to the OT, and these are the image from the OT. We can see that it's also associated with a sternum fracture. Most commonly the injury has when there is a compression of heart between the sternum and the vertebra, which leads to the blunt cardiac injury, or as we say in our this case, there is a rupture, right atrial appendages rupture is there. We taken the patient for the OT, we perform a clamshell thoracotomy, and we found there are 2 left atrial appendages defect were there, 1 into 2 centimeter and 1 into 1 centimeter in size. Approximately 500 clot has been removed from the pericardial cavity, and intraoperatively patient had a cardiac arrest. He was revived. I would like definitely I will mention here very good anesthetics team is there using the cardiac massage and defibrillator. The patient was revived inside the OT. And immediately once the patient is revived, he was well managed. BP has come above 110/80. Then we have decided we will put the external fixator immediately. Within the 20 minutes, we put external fixator, and fasciotomy for the compartment has been done. These are the images from the OT. There's a clamshell thoracotomy in the first image, and on the right side, we can see a large clot is there, which we have removed from the pericardium. And this is a small video I would like to share. If it is visible, this is what we have repaired. We have taken the control with the finger. We have put a finger where the site is bleeding, and then we have taken the suture around that finger, and finally we have tied. Then finally, patient on post-op day 5 or 6, he has developed a surgical site infection, which we have treated with the local antibiotics and regular dressing. On post-op day 5, chest X-ray was suggestive of lung atelectasis, which was managed vigorously with the chest physiotherapy and intensive spirometry. This patient has an persistent tachycardia, which is due to pain. Clamshell thoracotomy pains a lot. Then in the first site, in the intraoperative period only, we have an epidural catheter. Then with the help of the anesthetist and pain management team, this was taken care of. Then after 2 weeks, fasciotomy wound has been closed, splint thickness grafting has been done, and we have a 9-month follow-up of this patient. The patient was resumed to his occupation as a heavy motor vehicle driver. This is the final pictures of the follow-up. Then lastly, we have
Ruby, thank
Yes,
you.
sir.
Thank you very much. I'm extremely sorry to
it's okay, sir. It's okay.
Because we are running short of time.
Okay,
But we have a very important question from our delegates, that why CCT done in this patient?
So why CCT is done? Because when patient first, the thing is, we have done the most confusion we get is after draining the blood from the pericardium, we find there is no blood on the USG. We find there is no blood in the pericardium, but persistently the patient is having low BP. So if we have the pericardiocentesis and the blood has been come out, there is no further compression, then why there is a patient have persistently low BP? In that view, we were suggesting if there any injury we are missing in the abdomen. So this is one reason why. And secondly, patient was, when on the arrival, patient has BP of approximately 80/50. We did pericardiocentesis, that has been drained, and we have resuscitated. The patient become stable. Then only we have taken the patient for this CECT.
Thank you. And one more question.
And I also recommend that if the centers.
Dinesh, no, thank you. I think let Dr. Ajay respond to this.
No, sir. There was one more question. I was.
No. First question first.
Okay, Dr. Ajay, please.
Right first, because it will send a very wrong message.
Wrong message. Yes, sir. Agree. Absolutely agree.
So I think let Dr. Ajay respond to this. Why CCT? So with the patient with 80/50 BP, and to see blood in the abdomen, and you did not find blood in the chest and on pericardiocentesis, we do not shift the patient to CT. We shift the patient to the OR. So Dr. Ajay, your take on this?
Yes, sir. If the patient is stable, though the patient's BP was low in this patient, as the patient has also have his mechanism injury is very high, and as there is still we have a confusion that there might be some other injuries also associated with the cardiac injury, and we have a center where we can shift the patient easily to CT, and we can take the patient to OR. In this type of setting where we have all the facilities, we can do it. We can go for a CCT. But in the centers where the system is not established, it's better to take these type of patients directly to the OR. So for a practical purpose, we just went for a CCT to look after the other reasons of the low BP.
No, I think so next time similar patient comes to you, you will again take him to the OR, to the CT, not OR.
No, if the patient is stable, we can take for the CT.
Similar patient with 84/60 BP.
No, sir.
No, definitely no.
Okay.
One more comment I want to make, that in such patient in whom you have done a cardiac repair, applying an external fixator and doing a fasciotomy should be done at a second step. I would prefer not to do it. We would advise not to do it in the same setting.
Yes, ma'am, but we have a different team for that. That's why we have did that. Otherwise, it's better to postpone that type of.
Okay.
Then it is okay. So if two teams are operating at the same time,
Yes.
otherwise a slab or a Kremer wire to be applied in that setting, because already we are expecting blood loss there. So don't want to add to the misery of the patient. Thank you.
Thank you. Thank you very much, Dr. Ajay. And we all know that how much developed we are having developed trauma system, trauma academics at the AIIMS Rishikesh. And you are very much on the path of getting your vision into the reality. And we are all together with you. And we will be looking forward again to meet you very soon in our next sessions. Thank you very much.
Thank you. Thank you, sir. Thank you,
So
sir.
with this, I invite our next site in charge from CMC Vellore, Dr. Vignesh. Dr. Vignesh is working with the responsibility of assistant professor in the Department of Trauma Surgery at CMC Vellore. And Dr. Vignesh, now please, mic is all yours. And again, I request you and your residents, please limit yourself with the case and discussion so that we can wrap up our things on time.
I hope my slide is visible.
Yes, Vignesh, please.
Hi, hello everyone. Thank you. I would like to, at the outset, I would like to thank the organizing team and the staff members for giving us this opportunity on this platform. I am Dr. Vignesh Kumar. I work as an assistant professor with the Department of Trauma Surgery at CMC Vellore. And I'm just going to keep, with want of time, I'm just going to be quick. And I'm going to tell you about the past, the present, and the future of trauma here at CMC. So at CMC, we've generally been seeing about 7,000 to 9,000 cases a year, out of which about 15% of our patients are about priority 1 patients. And of these, about 2,000 to 2,500 patients require admissions every year. A majority of them are admitted by orthopedics, followed by neurotrauma. Trauma surgery, general surgery has been admitting about 10% of these patients, which is about 250 patients. This is due to the fact that we are a private institute and varied specialties are involved in the management of trauma victims. But however, what has happened recently for us is that the Department of Trauma Surgery has been established officially from June 2020. We see about 35 patients a week, and our admissions have shot up to about 350 over the last year, which is a significant 40% increase from the previous years. And apart from all of this, we have taken the leadership in managing all polytrauma patients. We also provide supporting care in managing other specialty traumas. What this has done for us is that it's helped us form our own protocols for our institute, which has helped in minimizing the delay in treatment plans for most of our patients. What the future actually holds for us is this. This is our very own trauma center, which will be a trauma and a super specialty center, which would be about 12 kilometers away from the main hospital itself. This is a trauma center which is under construction, and we hope to move there by the first quarter of next year itself. It's near completion. This trauma center will be serving to about 100-kilometer radius in and around the northwest part of Tamil Nadu. It will be also catering to about 200 kilometers south of our region. And we expect to see trauma along with acute care surgery patients at this center. So our future, and apart from that, what we've done as a department is that we've been trying to bring up our own very own trauma registry for the institute, and we've been successful in that. We've been successful in the fact that we've been able to get funds, and we hope, we are very sure that the trauma registry will be going live from the 1st of January 2022. This is a commendable job in our very nascent 1.5 years that we have been here. And apart from this, what we see ourselves doing in the next 2 years is we hope to become a full-fledged ATLS center. And we also hope to have our own MCH courses running in trauma and acute care surgery. With this, I would like to hand over the mic and the podium to Dr. Mahita, who's the resident and will be presenting on an interesting case.
Hello, everybody. I'm Mahita Rebecca Mane, a postgraduate resident from Christian Medical College, Bangalore. I trauma surgeons fight tooth and nail on an everyday basis. I would like to present 2 such instances where this turned literal and how we dealt with the same. First patient is a 26-year-old male who was involved in a road traffic incident. He was a 2-wheeler rider who hit a pedestrian while being non-helmeted. And he was intubated at his primary center and referred to us 5 hours following the incident. On initial assessment, his airway was secured with the ET tube and confirmed. He was breathing at a rate of 18 breaths per minute and maintaining a saturation of 95%, and bilateral subcutaneous emphysema was known. His heart rate was 160 beats per minute and blood pressure was 170 millimeters of mercury, and EFAST was reported as negative. Circulation parameters normalized on resuscitation and analysis. His GCS was E1, VT, and M4 with bilateral equal and reactive pupils. There were no lateralizing signs, and hypothermia was prevented in this patient. On secondary survey, the significant findings were maxillofacial fractures and loss of dentition. Contrast-enhanced CT of the torso was obtained, which reveals the ET tube in situ, bilateral diffuse subcutaneous emphysema, bilateral rib fractures with pneumothorax, and bilateral basal contusions in both lungs. On return from radiology, this patient was noticed to have worsening saturation with increasing ventilatory support. He had a cardiac arrest and required 4 cycles of CPR before he lost his attention. And bilateral ICDs were placed, and he was admitted to the ICU for non-operative management. Because of the unexplained course of events, a chest radiograph that was done in the ICU showed the ET tube in situ and no major hemo or pneumothorax bilaterally. Cardiac shadow and diaphragm was normal, and there was a right mid-shaft clavicular fracture with bilateral ICDs in situ. And because of the cause that we could not explain, we reviewed the clinical examination and radiological findings. On the secondary survey, the highlight was loss of dentition, and the imaging was reviewed, which shows a radio-opaque shadow on the right parasternal region in line with the right main bronchus. And these findings were confirmed on the CECT imaging, and which were missed on the first instance. This patient further went on to have a bronchoscopy and retrieval of the foreign body. This video depicts the snare that is removing the foreign body from the right main bronchus. and the foreign body was revealed to be a tooth. The post-retrieval chest radiograph shows the absence of the radiopaque shadow, and later this patient opted to seek medical care at another center and was referred elsewhere. Similarly, the second case is a 46-year-old man who was involved in a road traffic incident. He was a two-wheeler rider who hit another two-wheeler, and he presented to our center 1 hour post the incident. On initial assessment, his airway was clear, but he was intubated in view of low GCS. He was breathing at a rate of 28 breaths per minute and maintaining saturation of 90% on room air, which improved on oxygenation, and bilateral air entry was equal. His heart rate was 68 beats per minute and blood pressure was 130 by 80 millimeters of mercury, and EFAS was reported negative. GCS was E1, V1, and M5, with bilateral sluggishly reactive pupils with anisocoria. On secondary survey, the significant findings were of a depressed skull fracture with facial lacerations. The chest radiograph was obtained, which was the ET tube in situ, no major hemo or pneumothorax, cardiac shadow and diaphragm was normal, with a right mid-shaft clavicular fracture. A CECT was obtained, and in the CECT we noted that within the ET tube there was a radiopaque hyperdensity extending from the trachea all the way to the right main bronchus. So the chest radiograph was reviewed, and this shows a linear opacity extending from the trachea to the right main bronchus. As the foreign body was within the ET tube, we did a tube exchange, and the foreign body was revealed to be a broken part of the stellate that was used for intubation. Having seen these two cases in quick succession, we reviewed literature, and we found a few interesting cases. The first being a case of a 70-year-old man who presented to the emergency department with clinical features mimicking a tension pneumothorax that was revealed to be a tooth in the left bronchus, which required bronchoscopic retrieval. The second was a case of bilateral pulmonary aspiration of teeth and presence in two main bronchi, and the spontaneous migration of the teeth into the right main bronchus. This highlights that these findings were found on the day 3 and day 4 of the admission, which shows that there should be a high index of suspicion for these kind of incidents, especially in cases of trauma. The third was a fractured tracheostomy tube which had lodged itself in the right main bronchus and separated from the flange of the tracheostomy. So having seen these cases, our take-home message is that there should be a high index of suspicion for aspiration of foreign body, especially following maxillofacial trauma. One should exercise caution while intubation and extubation, mainly in an acute care setting such as trauma. We propose that there should be a pre- and post-intubation checklist, and we suggest the following DRS ABCD of reading chest radiographs in order to minimize such missed findings and to facilitate early retrieval of foreign bodies to mitigate complications.
Thank you. Thank you very much, Dr. Mehta. And again, with your presentation, you again reiterate the same thing that whenever in the doubt, follow the protocol, review your clinical examination, review your imaging, and there will definitely be something which probably we have missed, and we will be able to treat the patient. I'm sorry that we won't be able to take further comments from other faculties because we have to move on with our presentation. And in this line, I welcome our next site in charge, Dr. Vaibhav from KGMU Lucknow. Dr. Vaibhav, please. Hello, Dr. Vaibhav. I think Dr. Vaibhav logged out. So is resident Paras? Paras is there? Paras is also not there.
Hello. Yes, sir, I am there.
So you can start with your presentation of the case. Paras?
Yes, sir. Yes, sir.
Please share your screen and start your presentation.
So can you see my screen, sir?
No, we have not seen. We are not seeing your screen. Please share your screen first.
1 minute. So can you see my screen now?
No, Paras, still not visible. So I think there must be some technical issue. So if you can just give us a brief idea what is the case is all about. Okay, now we can see the screen. So I request you to please finish it in next 5-6 minutes because we are running already short of time, and just discuss the important finding of the case rather than case as a whole.
Yes. Myself, Paras Bhandari, posted as a senior resident in the Department of Trauma Surgery in KGMU. I'm going to present a case. A 24-year male presented to our emergency as a case of blunt trauma abdomen following a skid from a motorcycle happening in 22nd of January 2021 at 6:35 p.m. at the hometown Siddharth Nagar, which is about 250 kilometers from Lucknow and is having a 6-hour ride from KGMU. The patient was initially managed for 2 days in the local facility of district hospital and then was referred after getting deteriorated to our center. Hello.
Continue. Vignesh, I think your mic is on. Please mute. Continue, Paras.
The patient arrived on post-op injury day 3 on 25th of January 2021 at 11 p.m. with the symptoms of left upper quadrant pain with anuria for 12 hours. There was no pre-hospital information except for a CT scan which was done from outside. At the time of arrival in the primary survey, the airway was clear, respiratory rate was 16, saturation was 98% of room air, bilateral chest rise and air entry was equal, the chest compression test was negative. The pulse rate was 102, the blood pressure was normal, the pelvic compression test was negative, and the FAST was positive. On the Glasgow Coma Scale was E4V5M6, the pupil were normal size, normal reacting, all the 4 limbs were equally mobile. Only the abdomen was distended. There was slight tenderness in the left upper quadrant and the flank region. On the imaging, this imaging was done from the district hospital of Siddharth Nagar. The chest X-ray was suggestive of no positive finding. The abdomen X-ray was also not suggestive of any positive findings. On secondary survey, there was only one positive finding. The abdomen was distended, tenderness in the left upper abdomen and flank region. CT which was done from outside was abdomen of oral contrast. IV contrast was not used in the CT. The CT was suggestive of empty right renal fossa, suggestive of congenital absence of right renal kidney. There were also dilated left pelvic calyceal system and few collection in the right paracolic gutters. On the lab workup, hemoglobin level were normal. TLC was slightly raised, about 13,200 cell per millimeter cube. The polymorph were raised about 84%. The KFT was severely deranged with urea of 173 and creatinine of 9.23. There was dyselectrolemia with sodium of 125, so potassium of 5.96, and there was a slight increase in the bilirubin level of 0.25 and direct being 1.43. Then we have option of non-operative management versus a laparotomy. The patient was of solitary left renal kidney. Patient was initially shifted to ICU. A dialysis was planned, but later on the management of NOM was abandoned as patient started developing increased distension with signs of peritonitis, and the patient was taken up for emergency laparotomy. In the top finding, there was an absence of right renal kidney. In the left, when opening of the left renal fossa, we found there was a discoloration of left renal pelvis with upper ureter. There was a partial eversion of the left PUJ, minimal peritoneal collection, and there was a large urine collection in the retroperitoneum. Patient was managed by laparotomy with repair of the avulsed PUJ with percutaneous nephrostomy and DJ stenting with a single pelvic drain. These are some of the per-op picture. The ureter has been looped in the infant feeding tube, and we can see the ruptured pelvis with one anterior lip in the forceps and for the posterior lip of the pelvis in the finger of the surgeon. These are the repair of the pelvic calyceal system with DJ stenting and nephrostomy done. In the post-op care, the patient was orally allowed on post-op day 2. The nephrostomy and drain output was measured, and the patient was assessed vitally and biochemically. The patient have an improving course with a significant decrease in the KFT values on on the post-op day 4, the kidney function test came out to be normal. After 21 days, a nephrostogram was done. Nephrostogram was suggestive of a normal pelvic calyceal system with dye reaching to the bladder. The nephrostomy tube was removed on post-op day 21, and the DJ stent was removed 7 days thereafter. Post DJ stent removal, after 1 month, patient again developed pain and anuria, for which a CCT KUB was done, which was suggestive of PUJ obstruction, probably due to the secondary stricture due to the repair or fibrosis there. Urgent DJ stenting was done. Patient was taken up for elective VY pyeloplasty with the assistance of Department of Urology, and a DJ stenting was done. Now the patient has the DJ stent being removed, and patient is doing fine now. The challenges we faced during this.
Thank you, Paras. I'm sorry again to interrupt you, but I think we have learned that what probably we have learned that what the case was done, and definitely it is a very interesting case, because in a theoretical discussion we always come across that what we will do if we find a solitary kidney, but this is what you really did. And congratulations for managing the patient very well. I'm sorry to not being able to take further discussion. So I thank you all the site in charges. And before winding up, just quick comments from Sushma ma'am and Subodh sir about the continuing this ethos to further institutes. Ma'am. Yes, ma'am.
Thank you, Dinesh, for conducting the session so nicely, and it is very pleasing to see that everyone has so actively participated, and all the cases were so nicely selected and well presented. And hope this enthusiasm and this participation continues in the coming years also. And I really bank upon all the younger faculties for taking this way forward. Thank you all very much for the participation.
Thank you, ma'am. Sir, one quick comment from Subodh sir about why
Dr. Dinesh.
Sir.
I want to congratulate you for this wonderful session and the concept of Milap.
Thank you, sir.
And my one suggestion I want to give you that we have to increase the awareness about this specialty, the trauma surgery and acute care surgery. So still this specialty is in infancy, and people are not realizing that there is a need to develop this specialty in the country, and there is a need to develop the structured training program in this country. So through this Milap, I want to request you that don't keep it as a closed group discussion. You conduct the Milap every month or once in 2 months, and at least in your audience, and request all the site in charges to involve the general surgery residents, so that they will get an idea what is trauma surgery is all about, and which might persuade them to take this as a specialty in future. So this is my suggestion. Don't keep it a closed group within the specialty itself. So in your respective institutions, involve the PGs from general surgery department. This is
Yes,
my
sir.
only submission. I congratulate you, all of you, all the site in charges, for a wonderful presentations.
Thank you, sir. Thank you. Your comment definitely well taken. And from next onwards, we are going to do the same only. And I am extremely sorry to site in charges where I was not able to take their presentation prepared by their residents with the due efforts. So I'm sincerely sorry. And in the next session, whatever is left, we are going to discuss that. So thank you once again for taking pains and keeping yourself here. Thank you very much. And for the next session is going to be the mind benders. So whatever excitement you are missing so far, our quiz master, Dr. Mohit and Dr. Vivek, is going to bend your mind. You are going to come across a lot of fun fact which probably you never knew. And then there are definitely so many prizes also to be won by the residents.
Yeah.
Thank
so
you.
I just want to make an announcement. Anybody
sir.
can play the quiz. Anybody can play the quiz. any delegate can play the quiz. The only thing, you have to log in from the front end. You cannot play the quiz from the back end. So you have to log in again if you want to play the quiz, number one. But
As
the
delegate.
awards as delegate from the front end. So there is a link. Everybody must have received the link. If you want to play for fun, even the faculty can play. But the prizes will be awarded only to the residents. So we have the details of all the delegates. So the prizes, first 3 prizes will be awarded only to the residents. And I can see residents here. We will start after 5 minutes. Let them join from the front end. And our quiz master is Dr. Mohit Joshi and Dr. Vivek Kumar.
Thank
Over
you.
to Dr.
So we will be, sir, we will be taking 2 minutes break so that
Yeah.
delegates join
Yeah.
and we
Yeah.
prepare for our quiz.
Absolutely.
And then
AIIMS, New Delhi. So before starting the quiz, let's have some set rules of the game. And these rules are, no, this is a fun learning activity. Obviously, it's online. So the primary outcome is just fun with learning. The questions will be a mix of subject content and some interesting facts on trauma. All registered delegates and faculty, they can participate, but the prizes are only for residents who have registered. We have some exciting prizes for the winners. The winner will get 5,000 rupees, the first runner-up 3,000, and the second runner-up 2,000 rupees. So in this quiz, there are total 30 questions. There is no negative marking. So attempt all questions. You have 30 seconds to respond to each question, and your time will start as soon as the options they appear on your screen. Now, once this window of 30 seconds is over, then you cannot record your response. In case we have a tie, the participant who has taken less time to respond will be declared the winner. So hope that these rules are clear. So are you all set? Okay, so are you ready? So let's start with question number 1. And from here on, my friend, Dr. Vivek, will take you over through the quiz. Dr. Vivek, please.
Thank you, Mohit sir, for start. And we are very glad to start the quiz. So coming to the question number 1. So we all know the dangerous mechanism of injuries guide a patient's need for treatment at a level 1 trauma center. So the question is, which is not a dangerous mechanism of injury amongst these? And your time starts now. Options are the vehicle intrusion 30 centimeter, that is 12 inch on a non-occupant side, vehicle intrusion of 30 centimeter on an occupant side, vehicle intrusion of 45 centimeters on non-occupant side, or a vehicle intrusion of 30 centimeters over the roof. So the time ends, and so the answer is A, vehicle intrusion of 30 centimeters over the non-occupant side. The intrusion including roof of 12 inches, including the occupant side, is a dangerous mechanism of injury, and 18 inches anywhere over the non-occupant side with ejection from the car or death in the same passenger compartment. These patients need to be shifted to the level 1 trauma center for the utmost priority of the patients. So coming to the question number 2. So a very important aspect of operation theaters, the sterilization. So the question is, which chemical is used in plasma sterilization? And your time starts now. Options are peracetic acid, hydrogen peroxide, nitrogen dioxide, or ethylene oxide. So the time ends, and the answer is hydrogen peroxide. The sterilization systems use a low temperature S2O2 gas plasma technology to sterilize, and endoscopes and fibroscopes can be sterilized by using this system. So coming to the third question, we will present to you a chest X-ray, and you have to see that what is not seen in this X-ray. The options are A, pneumothorax, B, a diaphragmatic injury, C, hemothorax, and rib fractures. Your time starts now. The time ends. So the answer is C, hemothorax. We can see a pneumothorax over the left apex, upper area. You can see a diaphragmatic rent with herniation of stomach. You can see the rib fractures over the left side of the chest wall, and there is no evidence of hemothorax in this X-ray. So we'll be proceeding to the question number 4. So coming to the first, in which country the first trauma center was established? Your time starts now. Options are A, United Kingdom, B, United States of America, C, Russia, or D, Germany. The time ends. And the answer is A, United Kingdom. The first trauma center was built at Birmingham in 1941, and it was the first hospital to be established to treat primarily the injured rather than the medically ill patients. So coming to the fifth question, something about sports. Sorry. The question is, where was the first blood bank in India established? Your time starts now. The options are A, Delhi, B, Bombay, which is Mumbai now, C, Calcutta, which is Kolkata now, or D, Madras, which is Chennai now. So the time ends. The first blood bank was established at Calcutta in 1942 under the British India. It is known as All India Institute of Hygiene and Public Health right now. So now coming to the sports. A player was batting in West Indies tour of India in May 2002, and he fractured his mandible while batting. But later in the same match, he continued to bowl, and he also took a wicket. So who was the player? Your time starts now. The options are A, Mervyn Dillon, B. Anil Kumble, C. Cameron Kafi, or D. Javagal Srinath? The time ends. So the player was Anil Kumble. He fractured his mandible, and with a bandage over his face to splint his mandible, he continued to bowl in the match, and he also took the wicket of the great Brian Lara. So coming to the next question, there are many surveys in a trauma patient. We do a primary survey and a secondary survey in ED. We do a tertiary survey in the wards. So question is, what is the goal of a quaternary survey? Your time starts now. Options are A, to see the preparedness before arrival of a patient. B, to reassess and detect missed injuries. C, to prepare for transfer to the next echelon of the care. Or D, to assess the internal capabilities and external factors in austere environment. So the time ends. So answer is C, to prepare for transfer to the next echelon care. This happens in the austere environment, and there we have to see our preparation for the transfer of a needful patient to next echelon of the care. We have to see the stability of the patient. We have to see the transport needs, the capabilities of the receiving facility, the critical care needs, and the weather conditions. Zero survey is to assess the internal capabilities and external factors in austere environment, where we assess ourselves that what are the capabilities and resources which we have to tackle the trauma cases. So pelvic binders are an important conjunct for primary survey, where we manage the bleeding from a fractured pelvis. The question is, which is the correct way to apply a pelvic binder? The time starts now. The time ends. The correct position of applying a pelvic binder is B, centered at the greater trochanter with toes tight to internally rotate the hip joint. Coming to question number 9, name this trial. The trial which suggests that transfusion of blood products in 1:1:1 ratio versus transfusion in a ratio of 1:1:2. Your time starts now. The time ends, and the answer is proper trial. All these trials have contributed to management of trauma patients, but the proper trial of the pragmatic, randomized, optimal platelet and plasma ratios suggested that RBC, platelets, and plasma should be transfused in a ratio of 1:1:1. Now, coming to the world politics and movies. So this person is Ben Carson, Dr. Ben Carson. He was director of pediatric neurosurgery at Johns Hopkins, was the first dark person to head the department. And he is credited for first separation of occipital conjoined twins. And he also devised a new method to control seizures. And he was a candidate for president elections in 2016. So the question is, name the movie based on Ben Carson. The time starts now. The options are A, Hands of God, B, Divine Hands, C, Gifted Hands, or D, Blessed Hands. So the time ends. The answer is Gifted Hands. This movie was released in 2009 and it depicts the story of Dr. Ben Carson. So now I will request Dr. Mohit sir to continue with questions number 11 to 20. Mohit sir.
Yes, I'm here. So you can switch to question number 11. So we all know about CRASH 2 and CRASH 3 trials. The question is that the CRASH 3 trial explored the use of naxamic acid in which of the following? So your time starts now. So was it in traumatic brain injury? Was it in massive hemorrhage? Was it in non-operative management of splenic and liver injuries? Or was it in acute lung injury? CRASH 3 trial, tranexamic acid. So your time is up. And the correct answer is that the CRASH 3 trial explored the use of tranexamic acid in traumatic brain injury. So this was a trial which included more than 7,600 patients, and it suggested that tranexamic acid, it reduces early deaths in non-moribund traumatic brain injury patients, regardless of the severity. The next question, question number 12. We all know that chopping organs for punishment has been very popular in the historic times. We know the story of Shurpanakha. We know that the cutting of ears is called cropping. So your question is, what is bobitization? And your time starts now. So is bobitization chopping hands? Is it chopping genitals? Is it tonsuring head? Or is it pulling the nails out? Your time is up. And the correct response here is B, chopping genitals. Now, this was based on the name of Lorena Bobbitt, who was a victim of domestic violence, and she chopped her husband's genitals way back in 1993, and after which this term of bobitization was used. Here comes question number 13. And your question is, which of the following is not a damage control surgery? Your time starts now. So you have to answer whether splenectomy is damage control surgery, or whether extravasation of bowel is, or laparostomy is, or application of axial fixator is. One of them is not a damage control surgery. You have to identify that. Your time is up. And the correct response is exteriorization of bowel, option B. Why? Because in case the patient requires a damage control surgery, an anastomosis or a formal stoma is not made, the bowel is either stapled or is taped to tide over the situation. Here comes the next question, the question number 14. We know about abbreviated injury scale. So if I take the example, it is depicted like this. So there is a point which is called a dot. There are some figures which are called pre-dot, and there is a figure which is called post-dot. Now your question is that what this post-dot denotes? Your time starts now. Does it denote the severity of injury? Does it denote the region involved in trauma? Does it denote the type of anatomical structure which is injured? Or does it depict the mechanism of injury? Your time ends, and the correct response is option A, the severity of injury. Moving to the next question, question number 15. We all have seen this local active hemostatic. Haven't you seen it? Like there are 2 vials, 2 contents, 2 syringes. They are mixed and they are poured on to the bleeding surface. Now your question is, you have to identify and you have to name what are the contents of this local hemostatic agent. Your time starts now. So is it option A, thrombin, A-protein, and fibrinogen? Option B, thrombin, gelatin, and calcium. Option C, thrombin, fibrinogen, and calcium. Or option D, fibrinogen, A-protein, and calcium. Your time is up. And the correct response is option B. It's thrombin, gelatin, and calcium, as you can see in this wire. Here comes the next question. This is question number 16. We have heard many syndromes in trauma, like fat embolism syndrome, Brown-Sequard syndrome. Now your question is, there is something called as seatbelt syndrome. So what does seatbelt syndrome comprises of? Seatbelt mark and what else? Your time starts now. So is it seatbelt mark with vertebral fracture and hollow viscous injury? Seatbelt mark with vertebral fracture and pneumothorax? Seatbelt mark with sternal fracture or pneumothorax? And option D, seatbelt mark with sternal fracture and injury to a hollow viscous. Your time is up, dear, and the correct response is the seatbelt syndrome it includes seatbelt mark, vertebral fracture, and rupture of a hollow viscous. This brings us to question number 17. The next very question, who invented the surgical gloves? Your time starts now. Was it William Osler? Was it William Wilk? Was it H.A. Kelly? Or was it William S. Halsted? Surgical gloves, we use it every day. We cannot think of our lives as a surgeon without surgical gloves. Who invented them? Your time is up. And the correct response is it was William S. Halsted who invented surgical gloves. He is also considered as father of modern surgery. And among 4, he was also one of the co-founder of Johns Hopkins. Now we move on to question number 18. All of you must have seen this book, Top Knife, a wonderful book. And if residents, you have not seen this book, you have not read it, you must procure one. There's a wonderful book on trauma management. Your question is that who is the editor of Top Knife? Your time starts now. Is it Kenneth Mattox? Is it David Feliciano? Is it Ernst Moore or Mary Kay Allen? A wonderful book, very differently written, drafted very well. Who's the editor? This completes your time, and the correct response is option D, Mary Allen. He is very close associate of Dr. Mattox, and at present is administering the surgery division in Bentop General Hospital in Houston, Texas. We come to the next question. This is question number 19. So recently a Road Safety World Series cricket was played. It was a T20 match. It was played in 2021. It was played by all the retired players of various countries. So your question is, who was the winner of this match? Was it West Indies Legions? Your time starts now. Was it West Indies Legions, India Legions, England Legions, or Sri Lanka Legions? The time ends here, and the correct answer is no other than great India Legions. So this match was organized by Road Safety Cell of Maharashtra to raise awareness about the road safety, and the winners were our own Indian Legions. This brings us to question number 20, the very next question. Now this question is on some program called as ATOM. It's Advanced Trauma Operative Management. It's a training program of American College of Surgeons, Committee of Trauma. Your question is that which simulation tool is used in this program? Your time starts now. So for simulation in this program, do they use cadavers? Do they use high fidelity simulators with virtual reality? Do they use perfused animal tissue models? Or is it on live animals? This completes your time, and the correct response is that the ATOM course is conducted on live animals for simulation. So this was so very interesting. Now I hand over the further part of quiz to my friend, Dr. Vivek, who will take us through question number 21 to 30. It's all yours, Vivek.
Thank you, sir. So we will start with question number 21. There was a tragic car crash this year on November 1st, where we lost our Miss South India 2019 and the first runner-up. So the question is, which state they belong to? Your time starts now. Whether the Miss India belong to Tamil Nadu, B. Kerala, C. Andhra Pradesh, or D. Karnataka. Miss South India 2019 and the first runner-up 2019. Both died in the car crash. The time ends. The answer is Kerala. Dr. Anjana Sajan and Anshi Kabir both were the winners of 2019 South India pageant, and both died in this tragic car accident on 1st of November this year. So again, returning to trauma surgery, question number 22. So which of the following is not a component of damage control resuscitation? Your time starts now. Whether it is A, administration of tranexamic acid, B, administration of platelets, C, chest compressions, or D, damage control surgery. Which of the following is not a component of damage control resuscitation? The time ends. The answer is chest compressions. The components of damage control resuscitation include balance resuscitation, damage control surgery, and early correction of coagulopathy with transfusion of 1:1 ratio of RBC, plasma, and platelets, with institution of massive hemorrhage protocols and administration of antifibrinolytics and tranexamic acid along with the resuscitation. So coming to some important aspect of our surgery and organ donations. The question number 23 is, which country leads in maximum organ transplantation? Which country in the world leads in maximum organ transplantation? Your time starts now. Whether it is A, Spain, B, Germany, C, Sweden, or D, Finland. Which country leads in maximum organ donation and transplantation? So time ends. Answer is A, Spain. So Spain has the highest number of organ donors. They have 49 organ donors per million population. This was 2019 data. This is because of the policy in the Spain, where the non-donors have to opt out rather than opt in. In India, we have to opt in as a donor. We have to sign a consent. But in Spain and also in Croatia, they have to opt out of the donation program. Croatia is the second with 38 organ donors per million population. So coming to the next question. You see this picture of a boy. A wall collapsed over this child and he was buried underneath. This child has cervicofacial petechiae, subconjunctival hemorrhage, and cyanosis over his face. So the question is, what is the name of the syndrome associated with these findings? Your time starts now. Whether it is A, Perthes syndrome, B, asphyxial syndrome, C, Crush syndrome, or D, Hogarth syndrome. So very well, the time stops. Answer is Perthes syndrome. Perthes syndrome is basically traumatic asphyxia. When there is a sudden compression of the abdomen or chest over a closed glottis, when a heavy boulder or a heavy tree or heavy wall falls over the body, it is very unique in children. So it gives two clinical features like craniofacial petechiae, cyanosis over the face, and subconjunctival hemorrhages. So coming to the next question. So what is the cutoff value for intra-abdominal hypertension in millimeter of mercury? The time starts now. Whether it is 10 millimeter of mercury, 12 millimeter of mercury, 15 millimeter of mercury, or D, 20 millimeter of mercury. The cutoff value for intra-abdominal hypertension. The time ends. And the answer is 12 millimeter of mercury. Any sustained increase of intra-abdominal pressure of 12 or more is stated as intra-abdominal hypertension. So coming to the next question. So which template is used for transfer of injured in latest edition of ATLS? That is the 10th edition of ATLS. Time starts now. Whether it is A, ABCD, S bar, B, ABC, S bar, C, ABCDE, SPAT, or ABC, STAT. The template used for transfer of injured patients according to ATLS latest edition. So the time ends. The answer is ABC S bar. ABC is for airway, breathing and circulation, situation, background, assessment, and recommendation. This has to be discussed with the receiving facility by the transferring trauma surgeon. So we have often heard this saying that whenever two objects come in contact with each other, there is always a transfer of material from one object to the other, whether they're animals, human beings, or objects. The very well-known principle and very applicable in trauma surgery, also because of the medical legal issues. The question number 27 is, name this famous principle of forensic science. Options are A, your time starts now. Options are A, Borchards principle, B, principle of universal exchange, C, Staines principle of transfer, or D, Locard's principle. Whenever two objects come in contact with each other, there is always a transfer of some material from one object to other. So time ends. The answer is Locard's principle, a very famous principle. It was given by Edmond Locard. He was also called the Sherlock Holmes of France, and he is father of criminalistics in the world. And he established the first forensic lab in the world. So coming to the question number 28, see this picture. So what is the finding in a gunshot wound called? The options are, time starts now. Is it A, singeing, B, tattooing, C, blackening, or D, abrasion? The findings in a gunshot wound. So the time ends. And the answer is B, tattooing. It occurs due to subdermal deposition of gunpowder. So coming to question number 29, something related to the current affairs. So National Road Safety Month of 2021 was observed during which period? The time starts now. Whether it was A, 18th January to 17th February, B, 1st March to 30th March, C, 15th April to 15th May, or D, 20th August to 19th September. National Road Safety Month 2021. So time ends. The answer is 18th January to 17th February. So every year we have a road safety week, but this year in 2021 we celebrated a road safety month instead, and it was held from 18th January to 17th February. So next year it will again be the week starting from 11th January to 18th January will be celebrated as the road safety week. So coming to the last question. So I think everyone is well acquainted with this person, Benedict Cumberbatch playing Doctor Strange. And this is the same from the comic. So in the story, he met with a road traffic injury leading to quadriparesis, for which he took treatment from Nepal. So the question is, what was the field of practice of Doctor Strange before his accident? Your time starts now. Whether he practiced plastic surgery, B, he was a cardiothoracic surgeon, C, he was a neurosurgeon, or D, he was a trauma surgeon. The field of practice of Doctor Strange before he met his accident. The time ends. And the answer is, he was a practicing neurosurgeon and a spinal surgeon. So this completes the quiz. And we hope that you all enjoyed the quiz, being a part of this. So we will have the results shortly. Over to Mohit, sir.
So thank you very much for being part of this exciting quiz. So just give us some moment, give us some time so that we can prepare your result. So we have kept a tab of your responses. We know that how much time each participant has taken to record their responses. So we have everything on our software. Give us a few minutes so that we can compile the results. Again, thank you all for joining in this quiz.
Thank you, Dr. Mohit. So while you are preparing the result, I invite Dr. Sushma to announce the result of the award paper. And in the meantime, Dr. Mohit will be ready with his result of the quiz. And then when we will conclude the Trauma 2021 virtual. Dr. Sushma, please.
Thank you, Dr. Subodh. So, delegates, thank you for being here and participating in the quiz. I hope you all must have enjoyed the quiz. This year we had received about 68 abstracts, out of which total 65 were accepted. 3 were either 2 of them had withdrawn it at the last minute and 1 was not found suitable for the conference. Out of which 12 were selected for oral award paper presentations. So 6 in each group had presented on day 1 and day 2 of the conference. 14 were selected as oral free paper and they had presented on day 1 and day 2. So 7 had presented on day 1 and 7 had presented on day 2. And 39 were selected as e-poster display. So all those who had visited them in the gallery, they all were displayed in the e-poster gallery. And so out of the 12 selected for the award paper presentations, they were judged by a jury of 8 judges. On day 1, we had 4 judges to judge the papers, and day 2, we had another judges who had judged the papers on day 2. So out of those 12 award paper presentations, our jury has selected 4 papers for the award presentations. So I congratulate all the 4 awardees for this. The third prize goes to Dr. Piyush Gupta from Division of Trauma Surgery and Critical Care for his topic Upper Genitourinary Trauma Level 1 Trauma Center Experience. Congratulations, Dr. Piyush. And he gets a cash prize of 5,000 rupees for this. So congratulations. The second prize goes to Dr. Takio Tei for he's again from Division of Trauma Surgery and Critical Care, and his topic was to study the role of prophylactic antibiotics in patients with chest trauma at level 1 trauma center, a pilot RCT. He gets a cash prize of rupees 7,500 for this win. Heartiest congratulations, Dr. Tei, and congratulations to you because your paper also got through the 8 best presentation in the ATLS Asia Pacific regional meeting, and you had done very well over there. And so a special recognition of your presentation here also, and for getting selected throughout the region and presenting there at the ATLS Asia Pacific regional meet. Congratulations. And the first prize is shared by 2 people. The first prize goes to Dr. Jogender, MCH trauma resident, for his topic to study the effect of external pelvic fixation on the outcome of patients with fractures. undergoing damage control surgery, and he gets a cash prize of 8,000 rupees. Congratulations, Jogender. The first prize is shared by Miss Meenakshi Sharma. She is a PhD scholar in the Department of Forensic Medicine on her topic diffuse axonal injury in severe traumatic brain injury versus non-traumatic brain injury, pathological aspects as different time. She also gets a cash prize of 8,000 rupees. So congratulations to all the award winners for preparing their paper and presenting their papers. Congratulations again, and thank you very much for participating.
Thank you, Dr. Sushma. And we are ready with the results of the quiz. So I'll request Dr. Mohit. Are you ready with the results?
We are ready, sir. I'll just request Dr.
Yes.
Vivek to share the slides.
Yeah. So
Dr. Vivek?
Vivek.
सर मैं आपको पैनलिस्ट अपग्रेड कर रहा हूँ, आप एक्सेप्ट करिए उसको.
Sir, I'm sharing the result of quiz.
So I thank everyone who joined the quiz. It was really exciting. We already have the results. They'll be displayed shortly. And here are the winners of Mindbenders Trauma Quiz 2021. And the third prize goes to Dr. Preksha Rani, and she gets a cash prize of 2,000. Many congratulations, Dr. Preksha. We have second prize, and Dr. Mahita is the winner, and she receives cash prize of rupees 3,000. Many congratulations, Dr. Mahita. And the winner of the quiz, Trauma 2021 Virtual, is Dr. Pranay Kabiraj. And this winner, he gets a cash prize of rupees 5,000. Many, many congratulations, Dr. Pranay. Keep this up. With this, we complete the quiz session. Thank you all for joining in, and I congratulate the winners. Thank you so much.
Thank you, Dr. Mohit. Thank you very much. Just a small correction in the prize. The prize money for the award paper, the first prize is rupees 10,000, not 8,000 rupees. So all the award winners, they are requested to send their bank details, and their prize money will be transferred to their bank accounts. So with this, we come to the concluding session of Trauma 2021 Virtual. So we have with us the President of STAC, Professor M.C. Mishra. Sir, your comments.
Good evening.
The only comments, good evening, to make that I think it was the full day today as well. I've logged in since morning and following the events as they have happened, and there were some very good presentations and case scenarios from various institutions. So that was very, very encouraging to see that from Vellore and from other places. And also then the presentations by the faculty, and also to cap it now, the quiz was very interesting. And we all followed it, tried to answer that. Not every answer was correct. So that was that was good. I think the boys have worked very hard. So congratulations to the whole team under the leadership, Dr. Subodh, Dr. Amit, Dr. Sushma, and all the faculty. I could see the excitement amongst all the young faculty of Trauma Center, AIIMS, and other AIIMS institutions. So it has been quite a absorbing meeting, I would say, and we look forward that all those who are engaged in trauma care also work towards trauma prevention, as was highlighted. And we look forward to seeing everyone next year, but in between there will be some activities we shall plan during the 2022. So keep safe, keep healthy, and thank everyone. This was a virtual meeting. Maybe hope that we have physical meeting next year. I'm quite confident 11th and 12th November, when we have region meeting, we also will have, if the Asian collaboration works out, then we'll have all the 3 meetings together. So thank you once again, Dr. Subodh, Dr. Sushma, for sparing everyone is sparing their Sunday as well, and enjoy the evening.
Thank you, sir.
so much.
Thank you very much.
Sir.
So all the delegates, participants, we thoroughly enjoyed, and I am sure that you all have you will go with some message from the conference, from the lectures, from different sessions on the trauma surgery, trauma prevention, injury prevention. So I request Dr. Sushma, the Organizing Secretary of Trauma 2021, to conclude the meeting.
Thank you so much, sir, for guiding us, continuously being with us and guiding us. And we hope that under your leadership and guidance, the ISTAC continue to benefit the society, not only in the injury prevention part, but in the trauma care and trauma management. And let us hope and see more and more younger people join this specialty and help in the building a safe and secure society. So thank you all the delegates for joining us, and hope to see you all next year. And thank to Virtual MNC for providing us a flawless platform for the smooth streamlining of the conference. Thank you so much.
So hopefully we see you next year in person, physical. Thank you all very much.
Yes.
Signing off.
That's right.